well, we were not sharing this whole time? Oh my goodness, I'm sorry. We need to record, so now. Okay, good. All right, so Mark, take it over, and I think we can go into this.
Okay. Yeah,
And then
perfect.
you can use the quick typing.
Good. Thank you. So, fantastic to be here. We've been talking to Nagin for what seems like months, years, and it's finally here. So thank you to University of Maryland, School of Public Health, and to you for coming. I've got 8 minutes, and I'm going to be quite quick. The first part is just going to tell you a little bit about where we come from, and then the second part is to broaden out some challenges that the UK health system is facing. And my colleagues from Birmingham are going to go into a bit more detail on that. So I'm just the warm-up guy really for the two people that follow me. So just very quickly, Birmingham, middle of the country, second largest city. Interestingly, it's got about the same population, roughly, as Maryland. And this is one of the issues we want to kind of follow up. How do we organize health systems at that sort of 4 or 5 million population level? Not just organization level, but kind of issues of population health. The University of Birmingham itself, founded over 100 years ago, research intensive. It's got the oldest business school in the UK, one of the oldest medical schools, one of the largest in Europe. Some 400 plus medical students each year arrive, 38,000. We're a big player. The Health Services Management Centre, of which we are part, and this is actually our building. It's fantastic, over 100 years old, and we have the gardens as part of it. Last year we celebrated 50 years, so we're a bit older than the School of Public Health, and we're proud of that. We've been working on that boundary between research and practice for all of that time. Heavy emphasis on educational programs in these areas, so issues around leadership, policy reform, service and quality improvement, workforce issues, more of that later. We cover a whole range of different research topics, issues around technology, issues around leadership, issues around collaboration, organizational resilience, etc. So just a selection of our current research. One that I'd just like to highlight, because it's my new book that's coming out. Our health system is 75 years old in July, so we've got a book on that coming out. So we have a whole range of teaching programs. We've just started an MBA in clinical leadership, which is an online program, but the mainstay has been our Masters in Healthcare Policy and Management, and Nagin very kindly delivered a talk on that last autumn. But yeah, we have a whole range of other programs. And what we'd like to do is try and find some way of partnering with the School of Public Health, maybe across all of these, or at least some of these. So that's for discussions later this week. So onto the main kind of the main course, as it were. Just a little about the National Health Service, the NHS. As I mentioned, it's 75 years old, well, just short of, and it's funded centrally out of general taxation. There are regional differences for those of you that follow the UK. We do have 4 nations. We have Scotland, and Wales, and Northern Ireland, and England. They're all slightly different, which does create difficulty just for us to understand it. It's open to all. It's free at the point of delivery. By and large, there are no co-payments, minimal co-payments, and those that are levied, for example, prescription from your general medical practitioner, your primary care doctor, it's about $12, but 80% of patients are exempt for the reasons that you'd quite understand. So one of our finance ministers said that the NHS was the closest thing the British had to a religion. It is very strongly embedded within the culture of the country. So during COVID, children were chalking on the street, save the NHS, rainbows of it became a national issue about clapping. People would come outside their houses on Thursdays at 8 p.m. and it was clap for carers. There was love for the NHS. we'll see whether that lasts, but we'll come. The kind of general figures, 12% of our GDP goes on healthcare, and the NHS takes about 83% of that. So it's the dominant model. The other spending is private insurance, tends to be related to employer-based bonus packages for a relatively small number, and then increasing out-of-pocket payment. That 12% has increased dramatically during COVID for two reasons. COVID, we had spent a lot more on a whole range of things, but also our economy has been shrinking. So as a proportion, the pie has got smaller, the slice of the pie is relatively, so whether that 12% will last, as hopefully the economy grows, we'll have to see. So very quickly, this model is probably very similar to many of you. The flow of finance. So our taxes go primarily to the government, as I mentioned, 83%. Resource allocation to third parties, traditionally called commissioners, and they would have contracts with a variety of providers, primarily NHS providers, so hospitals, primary care, community health care, but it could also include an independent provider, and we have a small range of that, and they would then deliver services to patients. The red line in that top left box is all about redistribution. So the people who pay their taxes, the 83% of funding, are not necessarily the people who get the services. So there's an element of redistribution. Equity is built into the system at a finance level. Doesn't necessarily mean it's equitable in other ways. We'll come on to that. And just a flag, there's a workshop tomorrow on that one. So just a very quick patient journey. How would you navigate this? Let's say you have undiagnosed need, you've got a chest pain, your child's got a cold, it doesn't seem to be clearing up. Primarily the first visit would be to your general practitioner. Issues that we have don't have the number of GPs that we should have. So there's increasing demand at a time exactly of falling supply for our GPs, these primary care doctors, who on average would have about 2,500 people on a list. They're registered patients. You would register as you move into a community, you would register for your local GP service in the way that you'd register your children for school, for example. There are other routes into this. So you might go to A&E, which is our emergency room. You might also use NHS 111. It's a telephone number. You just dial 111 and you get through to an advisor. And most of the care that we would have, 90% of contacts with the NHS happen in that little circle. It takes 10% of the budget. It's the 90-10 rule. 90% of contacts, 10% of the budget. The other 90% of the budget, 10% of the contacts, happened in the secondary care and maybe in tertiary care. Then out into the community is social care. So these are funded differently, not part of the NHS. Good debate whether it should be. We'll leave that to one side. But that would be kind of social care packages looking after people post recovery in the community. Some of them might not need that. Many people do not, but particularly for older people with disabilities would need that. So throughout the system, rising need and demand, reduced capacity, primarily through workload. The expression of that is in waiting times or waiting lists. The list is a bit of a misnomer, but there's about 7.2 million people on a waiting list. We've got a population of 70 million, 10% could be. Delayed discharge, interesting that we're hearing from UMMC about that for different reasons, I think, which was interesting. And then social care, also suffering from shortages of staffing, low pay, recruiting staff into that. So we've had that. The system is starting to ossify, it's starting to slow up and become rigid. Does that then undermine the public support in the same way that they were clapping for us, for the NHS? And that's found particularly expression in terms of the issue of pay for staff. So For the first time ever, nurses went on strike in this past year. First time in over 100 years of the Royal College of Nursing. Nurses went on strike. And the Queen died. Oh my goodness, we've had two massive things this year. So for the NHS, what are our main themes? Well, we've got a global health budget. Generally, that keeps transaction costs low, minimal co-payments, rising pressure for that. We have a population health approach, supposedly integrated, but questions around that. Primary care is a dominant focus for access to the health system. But strangely, we do quite well on that, but we have generally poor health outcomes. We don't get a good outcome for an interesting issue in a school of public health here. Equity is built into the system, at least in theory, but not equity of outcomes. And right through all of this, the quadruple aim of workforce, vacancies, shortages, but also not just because of COVID, but accelerated, magnified by COVID, issues of burnout. I think I might have gone over my 8 minutes, sorry. A race through. So I'm going to pass to my colleagues and we will have a bit more detail on it.
Thank you.
Yes, so I'm pretty cool. My primary research interests are actually in reproductive technologies and genomic medicine. But today I'll be presenting on the impact of COVID on England's NHS and its workforce. So on the 16th of March in 2020, the government recommended that basically all non-essential activity would be suspended. And then a week later, that is when we basically went into our lockdown. During the first wave of COVID in England, roughly 56,000 people died. And that's our first wave went from March till sort of mid-July. At the onset of that, the initial response was that primary care all switched to a digital first response. So you wouldn't see your GP in person. You'd ring a hotline. If it was COVID, that had a separate hotline as well. And that would be the approach. All non-essential care was cancelled. So that's stuff like elective surgeries. Even people who were having various forms of chemotherapy, for example, you know, they had restricted access to care. Only the patient themselves could go into hospitals. So that was quite new. It was, if it was a child, it could only be one parent, etc. So it was very, very restrictive, as I imagine was the case across the globe. In the UK specifically, a lot of the A&E departments, the emergency rooms, they were sort of reorganized to accommodate COVID patients. Most of A&Es were just dealing with COVID patients at that point. Admissions, as you can imagine, were going through the roof because of how many people were coming in so critically ill and dying. So everything was overstretched. We had the same sort of problems that were shared across the globe with the lack of PPE, etc., etc. Even some healthcare staff weren't able to work because we were vulnerable people, etc. A lot of the wards were being repurposed across the hospitals to accommodate the high admission rates of COVID patients. That meant that a lot of the staff that were dealing with patients with COVID as well, who had to be put on ventilation, weren't necessarily trained to deliver that care in primary instances. So there was a lot of changes happening, obviously, and a lot of families were in lockdown. A lot of the healthcare staff were away from their families as well for various reasons. Some of it being obviously they were with COVID patients with poor PPE, but they didn't want to, you know, take that risk of transmitting the disease to their family members. We had the shortage of ventilators as well. Shortage of the staff expertise. And a lot of the staff were redeployed as well. So in the next slide, you'll see just how many staff were asked to work on a COVID ward when they wouldn't necessarily otherwise be in that position. And eventually, a lot of Britons will have various opinions on this. The government decided they were going to set up 7 bespoke hospitals called Nightingale hospitals to take the brunt of the excess admissions. But because of all the other issues that we had with the understaffing, etc., there wasn't actually anyone to support the running of those. So they were essentially a waste of time. Yeah, so that's just a slide across the board, and health professionals of all kind who were working on COVID across the wards. On the wards, and all the wards were high death rates. There were people dying alone. There were tough decisions being made. You know, hospitals were having to titrate oxygen. This wasn't something that, you know, you necessarily go into the health profession for. So it was quite taxing on, the health of mental health, of health professionals as well. You know, doctors were having to decide who to treat as a matter of urgency, and who to sort of have to accept to some ways that we couldn't treat, which again is very hard decisions, because at the end of the day, they're someone's loved ones. Old people, healthy people, children, everyone was dying. It was the same thing across the globe. Yeah, and like I said, again, health professionals were away from their families for all of this as well. So it had quite a significant impact on the workforce, but for some reason, because it started in Italy actually with them singing and them clapping, so we, as we do, decided to take from another country and started clapping on Thursdays as well at 8 p.m. And I have to say, from someone sitting at home, it was a very community feel, because you're all isolated in your homes, and then suddenly on a Thursday, you're allowed to open your window or door and hear for, you know, miles and miles on end, all forms of clapping and cheering and whooping and pans banging and drums beating and all sorts. So it was a really lovely feel for those first weeks, just in that you didn't feel so isolated. As time progressed, though, in terms of what it meant for those we were once considering heroes, it didn't really do much, because he never got a pay rise in the end, and that is what essentially led to the strikes that Mark's been mentioning. At the time, it wasn't very much just keep going scenario. I speak from at the time I was living with my sister, who was a senior sister in A&E. She was at the front line working. She was at the brunt of this, so she'd come every night and home every night. And we had her daughter was 1 at the time, so we got to experience it quite, you know, dramatically, everything she was going through. And at the time, it was literally just keep going, don't think about it. And I would be thinking, go on strike now, because now you get your pay, like, because they need you in the next day. But these big-hearted people, that's why they weren't there, and I don't. They were in there risking their own health with all this poor PPE, etc., and putting their own lives at risk, their own families at risk, to look after the rest of the nation. Yeah, so rightly so, the trade of heroes, but once science caught up and the vaccines were introduced, etc., that's when the government came into play again. And it got to the stage where they were trying to force these frontline staff who had gone in and risked their lives, who'd worked with poor PPE, to then say, well, now you have to be vaccinated to work. So we lost a lot of staff then. Some decided they weren't going to be forced to have it and weren't going to take that risk, and then left England, went to other countries where they didn't have to have the vaccination. Others just felt quite let down that they were going to be forced into this route or lose the job, etc. Some had to have it whether they wanted it or not, because they couldn't afford to take a different route and they had to keep the job. Yeah, and then we had the dip where things seemed to settle. We went a bit blasé, then we had a second wave, and that was far, far worse. And then post-COVID, it was literally that feeling of feeling quite abused, I think, with COVID settling. And then that's when, you know, it was sort of that, like when you're going on holiday and you suddenly get ill because you finally have time to relax. I think that's what happened to most NHS staff. I mean, once the major waves had finished and we got time to sort of just had a slight breath, that's when the PTSD kicked in. That's when the burnout started happening. That's when, you know, it started to crumble, because they'd got over the initial fight and they finally had that time, and it was hard. So then the NHS managers, they started bringing in wellbeing staff, started setting up more mental health support, etc. But ultimately, they were having to take time off work because they were so burnt out. The PTSD was so strong, so they were really, really struggling. Yeah, so that just shows the figures of staff burnout, which were higher in 2001, and it suggests that they were declining in 2002. That's not necessarily because conditions have improved, more so because staff are leaving the NHS, basically. The NHS itself employs 1.5 million people. For perspective, Walmart employs 1.3 million in the US. So it is the biggest employer that we have in England. As Mark mentioned, in comparison to other nations, England has a very low proportion of doctors relative to the population. The average number of doctors per 1,000 people in OECD EU nations is 3.7, but England just has 2.9. And according to the British Medical Association, England would need the equivalent of an additional 46,300 full-time doctors simply to put us on an equivalent standard. Yeah, and as of December 2022, there are around 124,000 vacancies in secondary care in England. So you can see there's quite a lot of vacancies numbers there, sorry, and roughly nearly 9,000 of those are medical staff. Yeah. Let's see, in the essence of time, I'll move on. Yeah. So that was the number of nurses leaving England in the past 11 years. It's a record high, as you can see. Yeah, so basically the impact of COVID on England's NHS and its workforce has been detrimental, even more. Now it's even more under-resourced and understaffed than it originally was before COVID. The lasting impact of COVID and the revelations from it have led to increased numbers of staff feeling undervalued, underappreciated, and we're just having these discussions about how important it is to feel valued at work yesterday in terms of retention. And the cumulative factors have led to record numbers of staff, NHS staff resigning, suggesting to regain some semblance of work-life balance. So that's the end of my case study, and I'll pass over to Jenny.
Thank you very much. Thank you.
Okay, brilliant. Hi everyone, my name is Jenny Knights. I'm a PhD student with Health Services Management Centre, and I'm also a specialist research lead with an organisation called NHS Education for Scotland. In the second of our two case studies, I'm going to focus on some of the ways in which the pandemic has impacted specifically on the dental workforce in Scotland. Now, when we talk about the dental workforce, we're not only talking about the 4,000 odd dentists, but also over 6,000 dental nurses and other specialties such as hygienists, therapists, technicians, dental practice managers, dental receptionists. Okay. So NHS dentistry is one of those NHS services where patients have to contribute towards the cost of their care rather than it being free at the point of delivery. So the first charges were actually introduced in 1951, and that was in an attempt to drive down overwhelming demand and the financial costs of NHS dentistry. So dentures were actually one of the very first items that were charged under the NHS, and this caused a lot of debate in government at the time and actually led to the resignation of Aneurin Bevan, who was the Labour health minister, and he actually resigned over this issue, having been crucial to bringing together the very existence of the NHS. So I'll just give a sort of brief overview of how dental services are organised in Scotland. The majority of dental provision is through the General Dental Service. And dental practices actually operate as independent businesses. Colloquially, we'll talk about high street dentists, and dentists are therefore operating as self-employed. Now, despite being independent practitioners, dentists providing NHS treatment have to have what's called a list number from their territorial health board. And you can see just on the left there, the 14 territorial health boards that we have in Scotland. Shetland and Orkney don't actually sit where they are, and they don't exist in boxes, just to be clear. They're a little bit further north than that. So all items of service that NHS general dental practitioners can provide and claim a fee for as NHS work are detailed in what's called the Statement of Dental Remuneration. We also have the public dental service. This provides access to dental care for patients which have particular special care needs, or where there may be learning difficulties or mental or physical health disabilities that preclude them being able to access the general dental service. And staff in this service are employed by the NHS and are salaried. We also have the hospital dental service. This deals with inpatients and day cases. Treatment is carried out not only the dental hospitals in Glasgow and Dundee, but also in the Edinburgh Dental Institute and in general hospitals across the country. And again, these staff are salaried and employed by the NHS. So how did COVID impact the provision of dental services and the work of dental professionals? Directed by the 4 UK dental chief dental officers, most non-urgent dentistry ceased at the end of March 2020. And dental practitioners were initially advised to triage patients by telephone, either providing advice, pain relief, or antibiotics. And there were arrangements put in place for the provision of urgent dental care as well. Now, a major issue came about with the ramifications of the pandemic for providing aerosol generating procedures. If you're not familiar, AGPs are basically medical procedures that generate tiny droplets of liquid suspended in the air, and these can carry viruses. So the reintroduction of AGPs was progressed under very strict protocols, and for instance, the use of enhanced PPE, and also the use of fallow time, which are periods which the clinic has to be empty for between treatments. And there was a great deal of uncertainty about the risk of transmission in dentistry, with the available evidence being constantly updated as new findings were published. And the Scottish Dental Clinical Effectiveness Programme did a very rapid review, trying to appraise the available evidence related to AGPs. I think this is a really good example of where experts have collaborated around trying to reach agreed positions that could be used to inform policy and guidance where high quality evidence was limited. And this significant reduction in the throughput of patients, this quickly exacerbated the perils of self-employment and running dentistry as a small business. And this was felt through dramatic loss of income and also complexities in terms of accessing available financial support. And this combination of factors, this resulted in increased frustration and discontent with the leadership within the dental world at all levels, and the professional bodies such as the regulator, which is it's the General Dental Council. In 2020, I was involved with a project called Career, and this was a research study that sought to understand how the COVID pandemic had affected the anxiety, feelings of uncertainty, and preparedness for practice of dental health professionals and trainees working in primary care settings in Scotland. And this was a longitudinal study, utilising a baseline and a follow-up survey, focus groups, and weekly diaries. At baseline, 27% of respondents reported significant depressive symptomology, and this compared with 18% in a population-based cohort in normal circumstances. 55% primary care staff rated themselves as emotionally exhausted. This was over double the rate of trainees. 36% of primary care staff felt unprepared for managing their health, including stress, compared with 15% of trainees. However, compared to baseline in the follow-up survey, trainees also reported a significant increase in their emotional exhaustion, although albeit primary care staff continue to exhibit higher levels of emotional exhaustion overall. And for the diary participants, fatigue ratings increased steadily. On average, over the period of the weekly diary returns, the average rating can be considered to be about 25% greater at the end of the study compared with the start. But interestingly, though, some staff actually felt less exhausted over time, whilst others deteriorated at a troubling and significant rate. So in other words, there was a substantial variation in the response of staff to the longer term nature of the pandemic. And I think this supports the view that staff differed strongly in their ability to manage the emotional demands of treating patients under the constraints of the pandemic. The qualitative data identified significant concerns surrounding the sustainability of dental services and dental training programs as a consequence of the emergency level response to the pandemic. I'll just give you a few seconds, if you can see it, and just to read the quote in the top left corner. So, can you see that? Just about. Ongoing uncertainties were affecting how participants were thinking about their professional futures, and stress about income, employment, many looking to move into more private work, some thinking about retraining, and others considering leaving the profession altogether. Just let you quickly read that second quote. So the restrictions on dentistry were also being seen to severely impede desirable clinical outcomes, particularly for the most vulnerable groups. Participants experienced being unable to deliver high quality care as both confusing and distressing. We talked a little bit yesterday about the idea of moral injury, which we'll maybe pick up in the talk later. It's my last slide. So where is dentistry now, and where are we going? Results from the British Social Attitudes Survey show that in 2022, satisfaction with NHS dentistry services fell to a record low, and dissatisfaction went to a record high. And NHS dentistry in Scotland is facing many complex issues, and I don't think it's any exaggeration to say that the system as it is in crisis. And that is in terms of access, workforce retention and recruitment, and also in terms of oral health inequalities. So a suitable long-term post-COVID NHS funding model is now urgent, not least for rebuilding trust between the profession and the leadership. And a payment reform process is underway. However, this has been delayed by the election of our new First Minister. But I believe that outcomes are expected on that in the autumn of this year. The considerable number of staff adversely affected, both professionally and personally, by COVID-19 requires investigators and researchers to assess their recovery, and further develop the evidence base needed to identify effective interventions to improve mental health. And I'm currently involved with I'm a chief investigator for another project called Mindset UK. And this is a programme of work where we're trying to do just that and set up an annual survey across the UK to evaluate the mental health of those working in the dental workforce. So thank you very much.
Thank you very much, Danny. Thank you. Now we're going to transition to University College Dublin. We will go over the Irish health system, partnerships during COVID-19 and critical care resuscitation during COVID-19. First, we'll hear from Kate Fraser, who is Associate Professor with the School of Nursing, Midwifery and Health Systems. Next, we'll hear from Thilo Kroll over there. again, Professor of Health Systems Management, School of Nursing, Midwifery, and Health Systems. And then we're going to hear from their doctoral candidate, their student, Matt Duma here, who actually is in Canada, but he is doing his doctoral program remotely with UCD, and he is going to actually be talking about resuscitation, critical care resuscitation during COVID in Canada, because that's his specialty. So Kate, take it from there. Thank you very much.
No worries. Hi, still in the morning. Good morning, everybody, and it's lovely to meet you all. As Negin said, thank you very much for the invitation to come here. My name is Kate Fraser. She said I'm an associate professor at School of Nursing at University College Dublin. And I suppose, you know, in my 6 minutes here, it's kind of like, how do I sum it all up? And, you know, the health service in Ireland, all about UCD, and a little bit about myself. So I thought I'd start with a quote from an Irish poet, the late John O'Donoghue. And what he said is, each of us is an artist in our days. The greater our integrity and awareness, the more original and creative our time will become. So you can decide how creative I am over these 6 minutes or so. So there you are. So in UCD, what I would say is University College Dublin. It is the largest university in Ireland. We have about 35,000 students, and it is almost 170 years old. So we're there at 1854. So we're kind of like hanging in there as one of the older ones. So as Negin said, what I'm going to do is talk about an overview of the health system and the role that the school has actually played within that, and the impact of COVID-19 on workforce and implications. And I suppose where I'm coming from, I'm a registered general nurse. So I'm a nurse, and the kind of the impact and sort of like what has happened with COVID and what we do and what we're about, and actually providing workforce is really to the core of who I am and what I am about. And I'm very fortunate that I'm in a school where actually I am engaged with practitioners who are nurses, midwives, and then wider health systems of interdisciplinary approach to supporting the broader health professionals. And then if there is time, and if there's not Negin, because she said to keep to time, I can tell you about what I did with COVID-19 and the impact in nursing homes where I was involved in that. My own research, what I would say, is kind of based in inclusion, health, and PPI, but for purposes of today, I'm very fact-driven, and that's kind of, you know, kind of like it's like having kind of a moment up here, kind of, you know, remembering all this. So this slide, as you can see, it's very busy. And really what this story is going to tell you is really what's Ireland about. We're a population of about 5.1 million people. The census was just completed last year. We're kind of like waiting tenterhooks to kind of tell us where it is, but we know it's increasing. And we've been very fortunate. We are accommodating 70,000 people from Ukraine who have come to Ireland as well. So they will be captured within that as well. So it's really, really important. And what we are is very much a funded public health system and funded by tax. We have a proportion that comes through voluntary health insurance as well. But part of our public health system is it's, you know, everybody has the opportunity to access the system, but when everybody is, then you're going to have waiting lists. So that's the reality of the system that exists. So about 45% of the population will have private health insurance purely for access. So, but we're all paying to the public system as well. The budget really that is provided to the health system is around 24 billion, and that's been increasing over years. I'm, you know, quite long in the tooth here. When I did my master's in public health way back over 20 years ago, the budget doubled from 3 billion to 6. So here I am telling you it's 24 billion. So you can see how far we've come. And we've a workforce of about 78,000 that work within the system that is controlled by the health service executive that really control it. So as you can see from that slide down there, we have a public, you know, private funding model. We are nationally split into 7 hospital groups, and the hospital is attached to one of them, the Ireland East Hospital Group, and I'll speak a little about that. Then we are also divided into 9 community health organisations to kind of have that split of what community looks like. And sort of within the last couple of years, and it's coming into play now in 2023, we are now going to be operating with 6 regional authorities. And where that is the integration. Because as you can imagine, we started with the hospital groups, we started with the community organisations, and finally we're bringing them all together under regional authorities. And I don't think we're any different to anywhere else where people have that way of working. And then within our regional authorities, within our community networks, we have 96 of them that are really kind of high, sort of the interface of where everybody is coming together. What our life expectancy in Ireland is at the top there of that graph compared to the other EU countries. So life expectancy is on average 82 years, and for women it's 84, for men it's 81. But mortality in Ireland very much drives our education in our school and our education in health services. So what are the big pillars in Ireland? Cancer, okay, so 31%, cardiovascular disease around 29%, and then respiratory disease. So there, when you're thinking, what are we providing education for? How are we supporting our workforce? Very much geared to those particular areas. So our school, what we're about leading education and about providing that. We are one school and a college of health sciences. The other schools are the School of Medicine, School of Public Health, Ag Science, and Veterinary Medicine. So what we are about is One Health, that broad global view of what health is about. And that there's great synergies then in working across schools within the college as well. And there are wonderful opportunities. And within our college then, what we also have is an academic system. We also have that it is connected in through with our hospital groups as well, so that we can respond very much through a health affairs brief to very much what is happening and adapt our teaching, our research, and our education for what's going on clinically, and be adaptable in that way. Here are some of our clinical partners. So what we have is the Ireland East Hospital Group, as I said, that represents 12 hospitals, major teaching hospitals that we are attached to, both St Vincent's University Hospital and the Mater Hospital in Dublin. And the Mater Hospital, as I said yesterday, they are just opened up their major trauma centre. So that's where actually there was great synergies there yesterday again. Then from mental health perspective, St John of God, and as you can see, maternity care, maternity hospital, National Maternity Hospital, and children's hospitals as well. And our programmes then are very much driven by our clinical partners. So you can see that broad base of what's coming in there. So just to give you that idea, we have 60 graduate programmes to meet the needs of the health service. And what do they look like? Well, you can see kind of from this word cloud, what we're talking about is advanced practice. We hear a lot about that. You know, it's no surprise that they're around cancer care, you know, graduate diplomas, critical care, emergency, leadership, management. And we are one of the colleges that provides education for public health nursing service. And we have just won funding to actually launch then a new graduate diploma in primary care nursing. And that's for the first time looking at supporting practice nurses, actually, and then community registered general nurses, because what we are very much about is our sláinte care is our health strategy, and it is about integrated care. We're 5 years into that. It was launched in 2018. And what that is about is really where our health system is, that providing integration to the right patient at the right place and at the right time. So what does that look like? And that we are then responding to that from the education and a research perspective as well, because we're a research intensive university. So how do our students shape the Irish health system through workforce planning? Well, you can see our undergraduate nurses, it's the degrees, whether it's the degree in general nursing, in midwifery, in mental health nursing, or an integrated programme of children's in general. And we also have over 1,000 top graduate students that are undertaking those clinical diplomas, and we have 46 graduate research students. So they are part of that. What are we about? If we were to take the WHO, they will tell us that we need 5.7 million or more nurses globally. And if we look at the Irish, the International Council of Nursing, they would say we need 9. So somewhere in between that, when we're looking at workforce planning, and it's the same for all healthcare professions, what do we do? Our graduate research students, again, they are that future driver as well. And again, they're coming from advanced practice, they're coming from clinical interviews as well. And also then driving that evidence base, which is really important. And I suppose during COVID-19, what really happened to our undergraduate students was a lack of placements. And for our graduate students, we couldn't place them in the hospitals, we couldn't place them clinically. For our students in the public health nursing program that I was teaching on, that changed dramatically. People went to what they call priority ones. There were no home visits. Home visits shrank to 15 minutes, which is very different. The priorities were, mothers and babies up to 9 months. So health screening and, that kind of, so when you're thinking of all these, the knock-on effects of all these other things, and never mind all that, just that mental health capacity, as I say, I want to be a nurse at 19. You're not expecting that you're going into hospital with full PPE going on. It also means that you may not have been able to rent because in fact, nobody wanted to live with you because you were working, you know, full on front line as well. So there were lots of challenges for many people as they went through. And for graduate research students, we pivoted our education for all to online, but for graduate research students, again, the impact of them, people couldn't do research, you know, that then went online and what happened. So I suppose just to sum up if I have time, and again, just kind of say, you know, there's a lot going on there. So you can see that kind of idea, but it's that we are there shaping the workforce that's really, really important. And, you know, wellness, I think, is critical. So for myself during COVID-19, you know, there I was, you know, pivoting online out of a room, out of my own house, you know, that kind of, you know, all things to all people. But what I also did then, actually, our college set up one of the national contact tracing centres. So I became a contact tracer, so that actually giving the diagnosis and following up clinically with people. Other colleagues then went back frontline, you know, working actually in care. So that space of actually moving right back in. Also then within that time, the college principal, who is consulted in public health, Professor Cecily Kelleher, she then was appointed by the Minister for Health to an expert panel to look at COVID-19 in nursing homes. And that was around May time of 2020, because what we were finding through contact tracing, through everything that was going on, that the challenges were greatest in the nursing homes, you know, kind of what was happening and where it was. So I was asked then to actually lead a team to undertake systematic review. That's trained in that, I'm a Cochrane reviewer. So that's what I did during that time as well with a team, and it was over 6 weeks. And the evidence from that then was actually used to kind of guide the part of that larger report then that went back to the Minister for Health, and then to look at actually how we are managing nursing homes, you know, and actually looking to see how do we support from a PPE perspective, the visitor restrictions, all the implications that are going on there. So that was huge in actually undertaking that review. So that went into the Minister for Health. Unfortunately, they published that. I don't know if anybody in the room here has done systematic reviews, but they published that review in the report. So then you couldn't publish it in a journal. So then we had to sit down the group and do another one over another 6 weeks. So that was kind of like, you know, when you're sitting in that one room, what did I do during COVID? I didn't see my family. So that was it. So I'll leave it there, and thank you very much. I'll hand over now to Tilo.
Thank you very much.
Thank you.
It's a great pleasure to be here. Thank you for the kind invitation. And I'm going to shift a little bit the focus towards PPI, or patient and public involvement, and we'll focus particularly on the impact of COVID-19 on the challenges for PPI. So if you hear me PPI, so here in the US and in other countries, you might hear public engagement or community engagement, consumer participation. So the different terms, you know, that are in use, we're using PPI. So in the interest of time, so I use that acronym PPI. It will speed up the presentation a little bit. So here's an official definition by the Irish Health Research Forum, how we see PPI, public patient involvement in Ireland. So in short, it's a meaningful, active collaboration of the public or patients in the governance, priority setting, and conduct of research, as well as in summarizing, distributing, sharing, and applying its resulting knowledge. So it's the whole research life cycle. And we heard a lot about tax-funded healthcare systems, but equally research and the underpinning of our health system, the evidence generation is tax-funded to a large degree. So it's just fair enough that the public and patients should have a say in how money is being invested, you know, what the priorities are, but also how research should be conducted. And it's a win-win situation really for all of us, because the research quality is improving because we get insights through the lived experience that people bring to the table to research teams. And the Irish government has massively invested over the last, I would say the last decade really, in promoting PPI. And at the moment, we're working on a national network of universities and over 60 national and local partner organizations that drive PPI in all of health and social care research across Ireland. And UCD is one of 7 universities at the moment driving this effort forward. This is what the network looks like. The national office is actually at the University of Galway, but you see there sort of all the university partners. And then as an example, for UCD, we have a range of organizations that we're working with: Transgender Equality Network. Kate mentioned the Ireland East Hospital Group. We have the Disability Federation of Ireland. We have Family Carers Ireland. The Dublin Simon community works with homeless and mental health challenges, spinal injuries in PQ. So a range of partners. And this is just the starting out point for writing the grant. And each of these university partners brings their own into this network. So what we're trying to achieve is to build really PPI capacity across communities, bringing education into the public and into the patient space, saying, so, you have a right to influence and shape research together with university partners. But in order to do so, we help you in your communication with the university. And on the other side, we're doing the same with our educational programs. We're embedding PPI in postgraduate, undergraduate education and in training packages. So ultimately, we also work with universities to work with HR, finance department, estate departments to create accessibility environments for engagement practices. We're working with the UCD Research Office, not only UCD, but across those universities, to really embed the notion of PPI in all those practices and policies. And ultimately, we want to grow the quality of PPI as well and have sustainable national network. These values and principles: respect, trust, flexibility, transparency, empowerment and power sharing, collaborative partnership building, and equity inclusion. These have been, and I'm conscious they are too small for you to read, but I'm sure the slides will be shared. These values have been developed, co-designed, co-developed in partnership with our community partners and individual patients through a range of activities. Some COVID-19 challenges: when we set out on this pathway to create this national network and related projects under this national network, obviously communication, relationship building with PPI partners was challenged. So suddenly we could not meet them. We could not go where they are because we were barred from that. We didn't have any digital infrastructure, and skills to use that digital infrastructure was highly underdeveloped. I think nobody probably had heard of Zoom, before we actually hit the pandemic. There was an added cost burden because not everybody could have this has a Zoom package at home installed, or could use it. The involvement of PPI partners in our research and training and education was stalled as well, even though our education overall moved online. Not everybody could contribute through that. And then I already mentioned, so the outreach engagement in community settings through travel restrictions, access restrictions, was severely impaired. So work was undertaken to really provide guidance for online practices. And these are some of the things that were incorporated in a publication that we contributed to and using online workshops that's led by Trinity College, our other major university, well, there are several major universities in Ireland, but our closest ally competitor locally. So in terms of what we had to work towards is reliability of technology, accessibility, building trust in using this technology, and developing online behaviors and etiquette, how to use that so that we don't talk over each other, that I'm guilty of at the moment. I don't explain, for instance, what's visibly on the screen. I should probably explain with every slide, what you see there. So you see there an image of a brochure, an online brochure. But those kind of things, how we use the technology we developed. Negin and her team, many of them I met for the first time. So there's a long list of, I don't read them for the interest of time, but we wrote together an umbrella review of looking at how COVID-19 public health measures actually were taking account of patient and public involvement. And the short summary, not great. So there was various stages. I have to say, I think for an umbrella review, it was fairly early on in the process because there was not enough review evidence out there at that time. Probably this should be repeated in a year or 2 years' time. But anyway, so anecdotally, we also saw basically every time you turned on the news, the public was not necessarily consulted. You know, you had people speaking to the public and informing them of what the next steps, but that engagement process was not happening. So we're not surprised. Just very briefly, two other examples that UCD had been involved in, one led by my colleague, Dr. Suja Somanathan. It's the Co-Vision project, and she looked at amplifying the children's voice during COVID and looked at how can we get actually a sense of how children and young people cope with the pandemic. And this was a global project involving New Zealand, Brazil, India, the UK, Ireland, Canada, and so on. It brought really young people together locally in children's research advisory groups, but also in co-design workshops. And they submitted also a lot of artwork to us. And so there's a website you can look and browse in your own time. A great project. And then Kate and I worked with the Dublin Simon community, which is this charitable organization, patient organization, or client organization that provides service for young people, for people who are homeless. And we received a small amount, Dublin Simon received a small amount of funding to look at the mental health supports for young adults who experience homelessness. And what we did is really, we developed a study which involved a photo voice component and a co-design element, which had different design stages where we worked with the young people to really tell us what that service would look like that would improve their access and their support if a pandemic like the one we experienced should happen again, but also in terms of the routine care that they need in terms of getting support through their organization. And we had very successful workshops and went through this process together and learned a lot from them. So I'm going to wrap up. This was a whistle stop tour. So in conclusion, the pandemic posed challenges for our network for developing it. We had to very rapidly move everything online. The public generally not well engaged in decision-making about pandemic-related public health measures. So it was very top-down. COVID-19 accelerated the use of digital technologies for engagement. So we really saw that people became more savvy. Just last week, we had a PPI event, and a lady joined us from her hospital bed, on a Zoom call, and we wouldn't have seen that before. So creative solutions were found using co-design responses and can be found, but we're also consciously aware, and that's not just a COVID-19 issue, that some seldom heard population groups might have been even less visible during the pandemic, because they don't have access to digital technologies and might be further marginalized in the process. So with that, I'm just going to end and hand over to Matt.
Thank you very much, Peter. Thank you. Going to talk about critical care resuscitation during COVID in Canada.
Thank you.
Thank you.
Thanks. It's a real honor to be able to speak about this. I study at the University College Dublin, though I am in Alberta, Canada, and I'm a nurse like Kate, and I'm on a mission to move patient to public involvement or engagement into the resuscitation space, involving families into the life-saving treatments of folks who experience sudden cardiac arrest and life-threatening conditions. So I think Alberta's greatest claim to fame is that we're that little gray box in North America that does not have rats. There are no rats in Alberta. We have a provincial program to eradicate all rats. That's our claim to fame, I figured. We've got we're a massive health system. We're about twice the size of France. We have about 120-ish employees now. We have over 10,000 physicians now. It's a massive health system, and which poses its own challenges. My role, I have an academic appointment where I'm a resuscitation scientist, but as an emergency and critical care nurse, my pandemic story starts with my being in leadership roles, and as times get more and more desperate, I return to the bedside. One of the first things that I was involved in, this is sort of my experience of the pandemic, is that early on, nurses were tasked to increase our workload with donning and doffing, putting on and taking off PPE, screening patients for COVID-type symptoms, and also doing more cleaning tasks. And though this, our health system was not ready to share this in publication, so this never went beyond this, and you get a little peek into the world of healthcare, was that in some roles in emergency departments, nurses were spending half their time doing donning, doffing, cleaning, and screening. And that increased. We didn't have to do any of that before, and that directly took away from the patient care that we were doing. So there are assessments, reassessments, vital signs, delivery of medications, health promotion, health teaching. Every nurse on a shift has a finite amount of time that they can spend with patients doing either high or low value tasks. And there's a massive shift into doing tasks that were essential, but maybe bring no sort of tangible value to patients. So we ended up, even before, because this was done very early on, bad COVID situations were happening in New York and they're happening in Europe, but in Western Canada, when everyone else was in their second wave, we were still having very low emergency department arrivals. So the signal that we're going to be in a crisis, even before people really started to burn out or stopped going to work or started getting sick themselves, we should have a crisis of time and allocation. So desperately, we had to come up with strategies to protect ourselves and actually free up nursing resources, our time, to be able to take care of patients. The next thing that I was involved in before things really went sideways was developing a critical care triage plan. So part of a team of physicians and nurses that would go throughout our health system. We'd be consulted by clinical care teams to determine, because we are a public system, publicly funded, publicly administered, to do the most, to provide the best care to the most people possible. We did develop guidelines for the withdrawal of care for people who are unlikely to have their clinical state improved. So to preserve our critical care resources, a number of bed spaces with ventilators, with skilled critical care nursing. So that was a challenging exercise, and actually challenging to perform as well, to begin triaging our available resources. While I was still able to do some resuscitation science research, you might remember that during the pandemic, we started to nurse or take care of patients more and more in the prone position, that belly down position. That wasn't something we did very often prior to the pandemic, maybe in like neurosurgical operating rooms for very, very fixed specific procedures. But now I was taking care of many prone patients on high flow oxygen because it improved their oxygenation status. So that posed a problem for us for the recognition, the detection and response of cardiac arrest and rapid deterioration. It's hard to tell if someone has cardiac arrest, especially if they're unmonitored in the prone position. They go from this position to that position, very suddenly. And it's very difficult to respond to. And it also takes a lot of nursing resources as you're getting spread thin to actually supinate them, to flip them over so you can do life-saving procedures and medications and chest compressions and that. So we were the first team to be able to use mechanical chest compression devices for performing those chest compressions to maintain blood flowing to the heart and brain with one of these mechanical devices. And we also developed a free for use 3D printing and CNC machines, a CPR board that in resource limited settings can be put underneath the patient to provide compressions on the back to buy you time to either defibrillate, provide medications. And then as things got especially desperate, even folks like me were pulled into critical care settings. So on the left here, typically as a critical care nurse, I would take care of no more than 2 patients in our setting. Generally patients, I'd have one truly critical patient and then another one who might be ready for the ward. They're ready to be discharged out of the ICU. But what ended up happening under the real strain of the pandemic is that I would take as many as 8 patients and I'd be assigned a helper from another setting. And a nurse is a nurse, and I'm grateful for all the help that we received, but it could be a lot like if you're trained to fly one aircraft, you may not be trained to fly another. It was incredibly stressful for my redeployed nursing colleagues who were used to their setting, whether it was children or babies or labor and delivery, whatever it was, to come and to help me with care. So a lot of that experience is really punctuated by trying to do the most for the most people possible, but not being able to meet everyone's care needs. So the lived experience of not being able to meet people's care needs would be trying to facilitate a good death for patients while you're spread between multiple tasks. We did a lot of, as we expanded into operating rooms and recovery rooms that had bad Wi-Fi access. So we would try desperately to get patients and families together connected by iPad. But a lot of my patients were stuck. We're just relaying messages to the family that they're deteriorating. No, I'm sorry that you can't see them. Do you have any messages that we can pass them? Let's see.
I like your timer.
Thank you. And then the last thing that I would say is that in all the places that nurses were forced to work in that we overflowed to, we were like closets and hallways and operating theaters. We weren't able to provide for the dignity of life or the dignity of death in those spaces. So really that's what weighs heavily on me, is not be able to provide an acceptable standard of care to the folks that we were challenged to take care of. So now many of us are leaving and retiring or reimagining our careers because the burden is so acute. Thank you.
Thank you very much. I appreciate it. You all can tell the screen in front of you went blank, which is on this home computer. So we have IT coming in to try to figure that out. But meanwhile, we will start having the US group come up, and let me introduce our last group is going to be our speakers from the United States. We are going to, or they're going to go over how we can optimize health systems for older populations, as well as care quality and practice and engagement in healthcare. First, we have Joe Flannery, who is a healthcare educator and safety and quality risk advisor. And I will say he is one of the instructors of the online MHA and online NPHM practice and policy program. Good friend of mine.
Make the slide while working.
Yes, and
While we're doing that, will you guys all do me a favor and just stand up for a minute? You've all been sitting.
for a while.
All right, I'll tell you when the minute's up, so don't get too comfortable. Okay, let's keep stretching, moving around a little bit. My background is actually in exercise physiology, so I can't watch people sit as long as you're sitting. One thing to take away from this presentation is remember that health is your freedom. And if you're not healthy, you cannot enjoy the freedoms you've all been hopefully wishing to be able to enjoy throughout your life. So we want to make sure, as we're talking about aging, we are all aging while we're sitting. And sitting is also known as the new smoking. So be careful there for those who like exercise type work. Okay, you can now have to grab your seat for a second. Thank you very much. I think I may be one of the few things between you and lunch, so I want to be able to move this thing along a little bit. Aging, by I look around the room, I can figure out why I got this assignment. I'm probably one of the older folks in the room. I failed retirement 3 times, so I'm not really good at retiring. As we come back this afternoon, one thing I'd like you to do is give me a definition of what a senior adult is. Not now, after lunch. So you think about that. Fair enough? Okay, this presentation is broken down into 3 parts, pretty quickly going through it. First of all, I want to talk about 6 transitional issues that we have not been very good at doing for the last 20 plus years. Okay, so this is what I call transitional changes, too slow to move is what it's really all about. In 2010 to 2030 in this country, United States, which we are today, 10,000 people a day turn 65. Every day, 365. We have a lot of folks, not only in this country, but around the world. Those are the booming generation. But we did a lousy job of moving from volume-driven healthcare to value-driven healthcare. We're still focused on we pay, we do everything else by inpatient care. We all want to do everything by ambulatory care, or a lot more, too slow to move. We've been talking about sickness. We don't have a healthcare system. We have a sick care system, moving from sickness to health. We always focus on the patient but not the population. How many people in here today are a patient? Okay, if you're not a patient, you don't think you are, you're just a patient in waiting. You will be a patient sometime. We have not moved from the acute care system to the chronic care system. When you're talking about the aging population, they don't have one issue. They don't have two issues. They have multiple issues, and we are not able to deal with those effectively. We're still into episodic care. We're focused on what's in front of us. We're not looking at a continuum of care, treatment, and services for those we don't see every day, and for those who are not putting a demand on the healthcare system. There's a lot of people out there we don't talk to ever because they're not coming to us. Let's talk about the world and just general populations. In 1950, the world had 2.5 billion people. 2010, 6.8. 2050, we're going to have 9.7 billion projected. We're getting bigger as a world. United States alone, we say we have 334 million. Notice the question marks. We don't have a clue what we have in this country. How many people came across the southern border in the last year? How many people came from the northern border? They like coming too, by the way. How many people came from all the other 2,000 countries in the world to this country? And how many people have left other countries to move around? We don't know. Those who are 60 and over, in 1950, we had 8% of the population in this country. Over 60, 2010, 11%. By the year 2050, we projected 21.2% of the folks in this country will be over 60 years old. 1 out of 6. It's a lot of folks who are what? Getting older. United States, again, population 334, not really, who knows? Over 80, not over 60, not over 65, not over 70, those over 80. In 1950, we had 0.6% of the population, 210, 1.6. By the year 2050, we'll have 4.1% of the population in this country over 80. The fastest growing segment of our society are those over 85. Okay. United Kingdom, I don't want to leave anybody out. You have 19% of your population over 60. Ireland's 19%, Canada 19%. Congratulations. Germany has 23% of their population. So it's not unique to your country, it's unique to the world. Supply and demand. We have a little couple issues with supply and demand, right? Plenty of providers. Somebody mentioned primary care providers. We don't have nearly enough primary care providers. Our world is turned upside down. We have 20% of our people taking care of 80% of the population. And how do we change that around? Not very well. Geriatrics alone. We have how many geriatricians in this country? Anybody have an idea? Okay, about 7,000. Half of those are full-time. Okay, we project that by the year 2050, we're going to need 30,000. We don't have to. Pretty scary stuff. Supply and demand. We don't have enough resources to take care of what we're dealing with. But just something to keep in mind. These are tipping points. Notice how the tipping points are laid on top of each other. One is balancing another, which is balancing another. The reason people are moving, the reason why populations are changing, you can't affect one little place without affecting all the places. If you lose balance on any one of those things, what happens to that balancing scale? We're already out of balance. How do we get where we need to go to? As I was thinking about this presentation, okay, one of the things I do in my spare time is I travel around the country. I've visited well over 1,000 healthcare facilities. I actually opened and operated a continuing care retirement community in Williamsburg, Virginia, and operated that for 5 years. I learned a lot about senior adults. And as we all age, there's only a couple things we want. And the word I'm able to share with you on that is the word purpose. As you age, you want to continue to have your purpose. You want to continue to be proud of what you've done in your life. A lot of pride there. Don't lose that pride. You want to continue to be useful. Okay, there's a lot of folks out there who want to share and benefit from your wisdom of age. You want to be respected. You want to be productive. Because when you lose that productivity focus, your usefulness and respect focus, things really go south in a hurry. You want to have options. You don't want one person to tell you this is the way it goes. All adults, all senior adults should be just treated this way. No, we are all still individualized. And remember, the population is going to be older, a lot older. And how are we going to deal with that? Everybody's a senior adult is going to be wanting to share. They want to share their experiences. But you can't share your experiences with people who don't want to hear about your experiences. I have a 14-year-old grandson. He's really good on my iPhone. He really is very proud of the fact that he can do anything I can't do on my phone. And when he tells me that, I always remind him of a couple of things. You're good on my phone. I taught you how to use a spoon. I taught you how to catch a ball and how to use a bat. Those are things you love doing today. You didn't know how to do that in the past. So let's help each other get through this whole situation. And then we also want to make sure that we are able to be engaged. Don't look at senior adults as people you don't want to talk to anymore. Hey, I'm young, vibrant, getting out and about, doing all my wonderful stuff. That's great. But what about what you can learn and what you can share and share together? You benefit each other. This is a little maze. I took this out of one of our textbooks that we use in the course. You'll work your whole life to get to where you want to be, and you want to make sure your health is there so you can enjoy your life. Remember, your health is your freedom. And people don't know where to do. They've waited. You don't plan to get old. It happens to you one day. One day when you weren't looking, all of a sudden you can't do something anymore. But how do you really get ready and be able to make that happen? This is a word I used a long time ago when I first got into taking care of senior adults and working with them, and that there's gold in old. That means, believe it, a lot of old folks have a lot of money. Okay, number one. Got to remember that. A lot of that wealth in this country sits in those who are over 65, 75, and 85. There's also a lot of gold in what they have to share. And it's a two-way street. You got to work together. You've invested in them. They've invested in you. Working together, we can work our way through a lot of the problems that we've now seen in this country. Hope that helps a little bit to give you a little perspective. We'll have more time for questions later on. Thank you very much.
Thank you. Next, we're gonna have, we have Arlene Bierman from HREx, Agency for Healthcare Research and Quality. She's the director for the Center for Evidence and Practice Improvement.
Actually, I'm now the chief strategy officer for the agency.
Okay.
That's okay.
Sorry about that. I wrote the wrong thing. She's with Mark.
I was
a
a director of the Center of Evidence and Practice for many years, so that's okay. So I'm actually going to build on Dr. Flannery's, and I was going to have everybody stand up too because of the aging well. So I don't need to do that, but it is really important to move. And I'm going to really build on what he talked about. I'm talking about health systems transformation and how can we reorient our health systems to really optimize health functional status and well-being as people age. And I'm not going to repeat all these stats, but I just want to mention a few things from the slide that life expectancy and active life expectancy are declining, and inequities on these measures are associated with race, ethnicity, and socioeconomic position are widening. And we know that low income and minority individuals age faster. There's a theory called weathering. And the good news is that much of this morbidity and mortality is really preventable. And then we're on a collision course because our healthcare system does not do this well and is really ill-prepared to meet the needs of the aging population, ill-designed as well. And so what we really need to do, as he mentioned, is move from a system that's focused, currently it's disease-focused and it's not person-centered, and it's focused on illness rather than wellness. Quality is suboptimal, care is fragmented, difficult to navigate and burdensome. And there's a hell of a lot of waste in the system. This is a paper from Will Schrank, was in JAMA a few years back, but he estimated there's $760 billion to $135 billion of waste in the US system, accounting for 25% of total healthcare spending. So when people say we can't afford to take care of the aging population, we can. We're going to be efficient. And we've heard a lot about clinician burnout this morning. I'm going to make a little connection, but we heard a lot about COVID today, about the connection between COVID and aging. and long COVID. And really, COVID was a disruptor and a wake-up call. And the first studies that came out on COVID showed that 88% of the people hospitalized for COVID had multiple chronic conditions. We take care of one disease at a time. And that the people with pre-existing conditions, including, cardiovascular disease, diabetes, etc., they're at a higher risk for getting COVID in the first place and having more severe disease when infected, and then at a higher risk for long COVID. And also, COVID infection has been associated with increase of other chronic conditions, including diabetes and dementia. So earlier we heard about syndemics. We really have a syndemic of multimorbidity in this country. And basically COVID is going to increase the burden of multimorbidity. And we know who's disproportionately affected by all of this. So this is a slide. It's been great hearing, from colleagues in the UK and Ireland, because, I practiced actually for over a decade in Canada. And what I learned practicing there, that even though we have very different health systems, people like to contrast, Canada with single payer and the US with our, fragmented, proprietary type health system. The problems at the point of care are the same. And there's incredible opportunity for cross-border learning. So the slide I'm going to show you next is actually from my colleague, Stefano Vella from Italy, about the problems of the healthcare system. And I think it'll resonate with all of us, no matter where we are. So we treat people too late. We treat people the same way instead of personalized care. There is, patients, we have our patients in silos. We don't know what really works. There's lots of medical errors, irrational workflow. We've heard about that. Patients ignore our advice, but we know the solutions. We could be proactive. We could personalize care. We need decision support. We need integrated care. We need to focus on real world evidence, patient safety, integrated care, and patient engagement. So those are all the themes we heard this morning. At ARC, we developed something called the Care and Learn model. The references on the slide. So there's a lot of really innovative research going on, and there's work going on learning health systems, how you could do data-driven, evidence generation, implementation, quality improvement. On the other side, there's a lot of work on care, person-centeredness, and we don't put those together. So we really need to remember that the health system is aimed at providing care, and that, but we need to learn and use data as we do that. I'm going through these quickly because, I think everybody wants lunch, but, you'll have the slide and we have lots of time for discussion and questions later. This slide is from CMS, and it shows that comorbidity among people with common chronic diseases. This is US Medicare beneficiaries, mostly over 65. And you can see that multimorbidity is the norm. So if you look at the last line, you probably can't read it from there, but if you look at heart failure, 99% have at least one other chronic condition, and close to 2/3 have 5 or more other chronic conditions. So it doesn't make sense to take care of one disease at a time. They're also responsible people with multiple chronic conditions are disproportionately account for costs. So, the 18% of people who have 6 or more chronic conditions, 5 or more chronic conditions, are over 80% of Medicare spending in the US. And we know their care is fragmented, there's duplication, there's avoidable harms that cost a lot of money. We could be much more efficient in providing care. And, talking about syndemics, I mentioned there's a syndemic of multimorbidity, and I'm not going to go through this now, but the one thing I want to emphasize on this slide is we need to focus on prevention of multiple chronic conditions, disability, and frailty as people age. We need to start. There's a lot of focus in the US on high cost, high needs patients, which is critical. We have to do that, but we can't ignore the prevention, and that there's a lot of we can do to prevent, disability and frailty as people age. There's a lot of complementary work going on. So I'm going to do like MTV Flash to just orient you towards this. But the Hartford Foundation is doing a lot on age-friendly health systems. but there's multiple age-friendly movements across the world. There's age-friendly cities and communities, there's age-friendly public health, etc. And we really, they put this really nice paper that was in JAGS a couple of years ago that's on age-friendly ecosystems. How do we work across sectors and collaborate to really make the world ready for an aging population? I think this is also, I'm in government. Oh, I didn't give my disclaimer. Nothing I say reflects the US government. It's my own opinions. But integrating health and social care is critical. I think maybe the UK does it a little better than the US. We're pretty bad at it, but it's a priority for the Department for Health and Human Services now. We had this piece in Health Affairs a few months ago and about the priority of creating community hubs, aligning community services, and figuring out how they can integrate with health systems so that people can get the care they need, address social needs, and the social determinants of health. There's also the National Academy of Medicine has recently, I think, really, I call them all landmark reports. I think one was on the roadmap for healthy longevity, which took a cross-sector view, not just focused on health, but there's a wonderful chapter in there on what health systems need to do. And they basically say that the need to shift healthcare systems to focus on healthy longevity to catalyze actions to be taken. And they include health systems in concert with communities and the people they serve should adopt affordable, accessible, culturally appropriate models. And that government should develop plans for aligning healthcare payment and reimbursement systems. And healthcare systems should measure care outcomes based on patient goals and preference. There goes that engagement again. A couple of years now, they released the Implementing High Quality Primary Care, gave a new definition of primary care and really focused on whole health. And I should let you know, in the next couple of months, the department is going to release its response to this report on how we could strengthen primary care across the US. We're behind the rest of the world in primary care clinicians. I'm actually a general internist, primary care physician, as well as a geriatrician, so a real minority, need more people with those skill sets. And the most recent report released by NASM was Transforming Healthcare to Create Whole Health. And this is key. Whole health is physical, behavioral, spiritual, and socioeconomic well-being as defined by individuals, families, and communities. There's that engagement again. And that we need to provide whole health care by interprofessional teams, and that we need the whole health system to be aligned that way. And I'm just my last couple of slides, these are slides from John Wong in Singapore. He was actually co-chair of the Whole Health Committee for NASM, and they're doing something really exciting. They're taking a whole community in Singapore and integrating multiple sectors to develop a whole of society, whole of government, real world approach. And their goal is increasing healthy longevity, enabling purposeful, where there's purpose again, longevity, promoting intergenerational bonding. I can hang out with some young people, support and community for all ages. I'm going to skip over that, but there's just one point I want to make on this slide here. There was a study published in Nature Aging. This was back in 2021. And health economists, and they decided that they found that slowing aging, increasing life expectancy by 1 year in the US would be a savings of $38 trillion, and over 10 years, $367 trillion. So I think we could make the business case for this between the waste and the opportunity. I mean, older people have a lot to contribute to society too and bring a lot of value. So just quickly, I'm cautiously, some days I despair at how big the problems are. Some days I'm cautiously optimistic. And I think there's really a window of opportunity here. There's growing recognition of the social determinants of health. The White House is going to be releasing a playbook in the next couple of months also on dealing with the social determinants of health, which is quite exciting. And we also have new methods and capacities for success. We have, digital technologies, new methods of research to answer these questions. So there really is great potential for effective use of healthcare dollars while improving quality of life and population health. And just to conclude, some of you may not be familiar with AHREC, some of you are. It's a lead federal agency for health services research. We're part of the Department of Health and Human Services, and we advance these objectives in a number of different ways. Convening functions, we bring together learning community. We fund health services research through the Patient-Centered Outcomes Research Trust Fund. We fund dissemination and implementation, clinical decision support and training. We provide tools and resources for both practice improvement and research, and as well as data and analytics. So we have MEPS HCUP data that you could use for studies. I should also tell this group, we also fund pre-doctoral, postdoctorals, and career development awards, and these are all topics of interest to us, so take a look at our website. And I'm just going to close. One of my favorite quotes is by Antonio Machado. He's a Spanish poet, and he said, "Traveler, there is no path. We make our path by walking."
Thank you so much. Next, we have Kristen Carmen. She is with PCORI, the Patient-Centered Outcomes Research Institute, and she is the Director of Public and Patient Engagement.
Thank you.
That's my.
Which way do I do this? Right.
You can use this for that. It's up to you.
Okay, beautiful. Okay, so I know everybody is hungry. There's two speakers here, but I kind of want to center you on this conversation, and I don't want to speed run too much, because I think a lot of what we're talking about today is a whole bunch of problems that I think thinking very carefully and clearly about how do we involve the people most ultimately affected. We're also part of the workforce and have to partner with our healthcare workforce to achieve the outcomes that they want and the workforce wants are really critical. So I'm going to try to tell you just a little bit about PCORI super quickly. I just want you to understand where we sit in the ecosystem. Our approach to engagement, I'm very familiar with our colleagues' work in Ireland, and very excited to see the work that you're doing and how it's expanding. I'm going to talk a little bit about what we've learned, because I think it's really important to this conversation and some of our future steps for knowledge. PCORI is unique in the ecosystem, so we are not a federal agency like AHREC. We were actually created by Congress. We are funded through a fee on our private insurers. But ultimately, we were created, and we're probably the youngest organization here. We were created 2010, reauthorized in 2019. But our primary purpose was to really help address this issue of how come it takes so long to get findings into practice, 17 years, et cetera. So our work is to help people make informed healthcare decisions, to improve delivery and outcomes by producing information and research that comes from research guided by patients, caregivers, and the broader healthcare community. So this high integrity information comes from this partnership across a spectrum of stakeholders. So what makes us unique in the ecosystem is that we aim to produce evidence that can be easily applied in real world settings. It's pragmatic real world research, right? It's very pragmatic real world. We answer questions most important to patients and those who care for them. That's critical to what we do. And we engage all of the individuals you see on this slide in all of our processes. What I want to note here is this pipeline. I'm not going to spend a ton of time here, but it's the depth and breadth. We are an environment, we are uniquely funded, but also unique environment in that we have involvement all the way from research partners and capacity. How do we help people build capacity into our topics? What do we study? Merit review process, what do we fund? We also require participation of patients and other stakeholders in our research projects and the dissemination. So when I talk to you a bit about what we've learned, it's from this extraordinary laboratory of over 600 projects to date. I just wanted to note a lot of our research is guided by these stakeholders, right? So we've funded nearly $4 billion to date. We've had more than 2,400 research related projects. That does include that capacity building, but also the actual research awards. And we also, what is important about PCORI is not only do we have this extensive engagement, and not only do we fund clinical comparative effectiveness research, right? Comparing one treatment to another or one delivery system thing to another. But we also fund dissemination and implementation extensively. So it's that soup to nuts perspectives. I think that's really critical. We also develop research infrastructure as well. What I was asked to talk about today is engagement and how do we engage communities, populations, and multiple stakeholders together. So I'm going to talk to you a little bit about this approach. Why do we do it? And you've heard a little bit about this because we want to influence research to be patient-centered, relevant, and useful, right? So they have a seat at the table, but actually what gets studies matters to people and they'll use it to establish trust and legitimacy in findings and also to encourage successful uptake. In our early work, it was guided by this rubric, which gave some basic ideas. It didn't tell people what to do in PCORI, but we said you had to involve people in research projects. This gave them kind of the span to think about everything, planning all the way through dissemination and underlying values. Again, this was non-prescriptive, right? This was like, you must do this, but here's kind of a framework for doing it, do it as you will. So what have we learned? And remember I told you we started in 2010, we're now at 2023. What have we learned from this laboratory? And this is the 50,000 foot view. Well, we've learned that engagement's feasible in all phases of comparative effectiveness and with a variety of stakeholders, meaning it can happen and everybody can do it on the projects. It can influence the design and conduct of the studies. And so what that means is you get a lot of really good information and pragmatic real world research about how to make studies feasible, acceptable, patient-centered, et cetera. And that's the impact. Partner involvement is dynamic and nonlinear. It's not one thing, it's many things, and it can benefit everybody in the process. It benefits not only the patients and the stakeholders, but the researchers who learn a tremendous amount about the lived experience, which is really necessary for real-world research. We believe that we've influenced the culture of healthcare research. We know there's challenges to address: infrastructure, resource, people and teams, and balancing views and priorities, which I'll talk a little bit more later. And there's a lot more to learn, which is really what I'm going to be emphasizing here when we talk. The thing about these challenges, I just want to note, we often hear, and I'm sure my colleagues in other places have too, it's hard to do engagement. What are we going to get out of it? Ultimately, what you learn from this helps you do pragmatic real world research. And if you're going to create information that's meaningful clinicians and patients and others to use in their daily lives, pragmatic research is necessary, and understanding the things that are going to make those studies work or will be a challenge in the study or make it impossible for a clinician group to uptake it, even though it's challenging, is exactly the information you need to learn. This is sometimes it feels abstract to people. I put this slide in just to remind you, when we talk about influence on study conduct, it's the discrete decisions, events, behaviors, and strategies in a project. What should be the outcomes? How do we do the recruitment? What should the materials be? The impact is how it shapes the more intermediate outcomes, right? It focuses on the feasibility, the relevance, the patient-centeredness. I already talked about the challenges. So coming out of this laboratory, and I have a number of slides at the end because I had to do this in 8 minutes, there's a lot of our resources that we created. So we have this pragmatic real-world research environment where we're learning about engagement in real time from our projects and our PIs who have been creative and innovative, as well as our partners. And so from that, we've created a lot of tool and resources. You can see in the slides about how to understand research, how to understand and work as teams in engagement. But we have also learned that we need to update that rubric. Remember, I said to you, the rubric says, hey, here's some good ideas. Why don't you think about doing these, but you just have to do it. Well, we have years of research and study. So we're now revising our rubric. It should be out in a draft form this fall. And we're updating this with the knowledge we've developed in this laboratory, addressing the facilitators and the barriers we've heard about, providing additional guidance and tools, and really to address our priorities. That is to say, we're a learning report as a learning organization. So we're taking what we've learned and we're now going to be putting into our guidance. We also have developed a Science of Engagement PFA, which is a very unique and important next step. So coming out of this, we've learned a lot from the practice, but we also know we need more evidence-based and research-based information. So we've created a PFA, which we're now have gone through 2 and we'll be into our 3rd cycle. We've had 1 set reviewed and we're going through some final stages. We have LOIs from others and we have yet another round. So we have 9 cycles funded by the Board of Governors, and we're going to be starting our 4th cycle soon. So Anybody in the United States or in other places who have United States partners, please look at this PFA. Where we're at right now is to build an actionable evidence base that clearly identifies the methods and approaches that lead to effective behavior. Right, this is what our PIs want, this is what patients and everybody else wants. And to do this, we're going to support projects that are also going to develop and validate measures of engagement. So the path from funding to impact is really about build the field. We get better engagement because we have more evidence-based, efficient, aligned, equitable, and meaningful engagement. That leads to more meaningful comparative effectiveness research, more patient-centered, diverse, relevant, high quality, and trustworthy. And ultimately, this leads to better practice outcomes, right? That's the model here. I just put these on the slides for you to see. It's basically to say that we are at this point where in the field, in the development of the field, the key questions we're answering right now are the ones highlighted in the brighter color on the left, right? What defines successful engagement? Whom? How can engagement be measured? Which I mentioned, what indicates that a study is patient-centered, as well as what are the approach that support and achieve successful engagement, particularly for underrepresented populations. This is our first stage and our first priority. If you look at the two that are not bolded underneath, that's really the next stage in the research. So you'll be familiar with implementation and the history of that kind of research, right? Getting to under what conditions, what works best, and et cetera, has to come at a later stage when you have this research done. These PFA priority areas are on the right, which I just mentioned to you as well. The one thing I wanted to note that why measurement is so important for us is it's both for the engagement science about what's effective, user-centered approaches, and understanding how it affects people, but it also helps the practice, right? How well they are engaging, where you can improve, and making engagement easier and more widespread. There's a resource that we have on our website for those of you interested in the what should priorities be. We put it on our site. That's really more about the priorities and contextualization of measurement. Would love to hear any feedback that you might have on this. We took not only from Pecori's work, but across the field to think about what these issues are. And then one thing I want to note is while we think of engagement on a continuum, remember I told you that rubric said you can kind of do what you want. We've also learned that engagement does sit on a continuum from input, which is research on focus group surveys, all the way through shared leadership. One of the things we're moving toward is saying, while input might be a necessary condition for engagement, it is not sufficient. You have to do more. And we've actually started putting this into our PFAs and specifically the science of engagement, where input is an insufficient approach to engagement. You have to actually engage people substantially. This is just the funding that we have. Very exciting to have 36 million over 9 cycles. And I know we'll have discussion later. This is how you can reach me. And at the end, there's a number of slides I'm going to go through. These are just references and resources to share with you, and also key citations, because I know this is a research-oriented audience. Thank you very much.
And again, all these slides with everyone. And our final speaker is Dr. Mangala Gulati. She is the Chief Quality Officer and Patient Safety Officer with the University of Maryland Medical Center. Before you start, let me just tell folks, we are putting lunch out here for individuals. So after Dr. Gulati is done, grab lunch, eat, and then we'll still start around 12:45 with our Q&A, but then we can eat and talk and be very informal about that. So no worries about that. Thank you so much.
Great. Thank you for the invitation. And always as the final presenter, I'm between you and lunch, so I will make this as brief and entertaining as possible. So I'm going to talk about a couple of different things. I'm going to talk about the global budget in the state of Maryland, how we get paid for the care we provide or don't get paid for the care we provide, and a few other things that I thought might be of interest to you. So University of Maryland Medical System, we are one of the largest medical systems in the state of Maryland. Our mission is to provide care to the residents of the state of Maryland. You can see this is our footprint. We go all the way up from touching the DC border, all the way across to the Eastern Shore. I'm going to talk, this is the governance structure. I'm not going to go through this, but just a very high level of how we govern all of our schools and how we govern our medical facilities as well. So we're going to talk about the 2 hospitals in Baltimore City. There are 2 hospitals, the medical center, and we have 2 hospitals. We consider ourselves one hospital, 2 campuses, but under CMS guidelines, we're actually 2 distinct hospitals because that's how we get reimbursed. The downtown campus is the academic medical center. It's very old. We are one of the oldest teaching hospitals in the nation. And we're also, in addition to the medical school, we also have the School of Nursing, Dentistry, Law, Pharmacy, Social Work. So we are inundated with learners, which is absolutely fantastic because we get to train the next generation of healthcare professionals. As you've mentioned, you've heard before, the US is going from a volume, meaning the more I do, I get paid, to the you need to do less and do it well, and then we will pay you. So really from that volume to value concept. In Maryland, each acute care hospital gets a fixed budget. It's called the global budget. So for an organization, I'm just going to pick a number, you would get $1 million to run your hospital. And the way they calculate that number is they go back and see how many admissions or discharges did you do last year? How sick were your patients? What was their case mix index or the acuity of care? How many patients were in an ICU setting, and a whole other number of variables. They then say, next year, I'm going to give you this much money. I'm going to give you 1.2 because you took care of some very, very sick patients. But in that $1.2 million, you're going to have to run your hospital. You have to run your operations. Salaries are our biggest cost, as you can imagine. During the COVID pandemic, you could be a nurse at the bedside, working beside a traveling nurse who was getting paid 3 times your salary. That contributes now to a lot of burnout, and you've heard a lot about burnout. Utilities, how do we keep the lights on, the electricity going? Equipment, we need CT scanners, we need MRIs, we need IV poles to be able to provide medications. We need to innovate, right? Where's that next big idea? How do we fund that? How do we make sure we're in compliance with regulatory agencies, such as the Joint Commission and the state requirements? And technology, we need computers, we need EKG machines that read the EKG and then transmit it into our electronic medical record. And we need to repair things. If that CT scanner goes down and we cannot repair it, guess what? It's going to slow our throughput of our patients. So this is, when you think about that 1.2, which is not the number, you can see that our money it's very, it runs out pretty quickly. And what happens when it runs out at the end of the year? We're either not fixing that CT scanner or we're closing a unit, we're closing beds. And that impacts the care that we need to provide to all of our patients. So there is a program called Pay for Performance in the state of Maryland. We are a unique payer system. And in this, really the mission was in the 1970s to make sure that all Maryland hospitals provided the highest quality and the safest care to all of our residents. Back in 2010, they developed something called the Quality-Based Reimbursement Program, followed shortly after by the Maryland Hospital-Acquired Conditions, which in the rest of the country are called Hospital-Acquired Conditions. And then the Readmission Reduction Program. In the rest of the country, it's called the CMS Readmission Reduction Program. So these are the kind of just a breakdown of the global domains. And the quality-based reimbursement, there are 3 pieces of that pie chart. You have the patient experience. That is based on a survey that goes out randomly to patients. They can fill it out. I used to be just by postal service and phone calls, but they're actually now making it electronic. They're actually moving with the times. Also, there are 6 chronic conditions that we should be providing timely follow-up for those patients: COPD, hypertension, diabetes, in an appropriate time frame. Because if we don't, then those patients tend not to get the right care, and that impacts impacts these patients and the population, the health of the population. Hospital-acquired infections. During COVID, we saw an increase in hospital-acquired infections because we were not going in the room as often as we used to. We were not changing our PPE. We were trying to conserve PPE. And what we're seeing now, prior to COVID, we had seen about a 20% reduction nationwide in hospital-acquired infections. The pandemic undid all of that. And we're just trying now to get back on footing to reducing our hospital-acquired infections nationally. The other one is surgical mortality complications. These are things after surgical procedures, and inpatient mortality. That is the quality-based reimbursement part of this. Then we have, in Maryland, we are very privileged to be special compared to the rest of the nation. We have 14 very specific, potentially preventable complications, which when you look at those, they all make sense. These should not happen to patients when they're in an acute care setting. Then we have the readmission reduction program, and I really always share this because it kind of causes a visceral response. In the state of Maryland, if you're admitted with chest pain and we take care of you and we discharge you, and you go out and unfortunately get involved in a motor vehicle accident, come back to any hospital in the state of Maryland within 30 days, it's a penalty. So tough, right? Because we took care of the index admission, but something else caused the patient to come back. There's a penalty associated. This is just a quick overview of the publicly reporting ranking programs. You as a consumer of healthcare can go in and look these up and see where should I go for my care? How does this play into my decision making? You can see at the left-hand side, you'll recognize those 6 domains of the Institute of Medicine's domains. Care should be safe, timely, effective, efficient, equitable, and patient-centered. And you'll see, ignore that first column for a second, all of the others are publicly reported quality programs. That first one is not publicly reported, it's called Vision. Vision is a national database that all hospitals can, if they choose, submit their data. And that allows, for example, the medical center is an academic medical center. I can go into that database and say, show me all the hospitals that are academic medical centers. They have a transplant center or a trauma one program, and they have more than 25,000 discharges a year. And I can say, wow, your infections look really good. What are you doing? Because we always in healthcare like to say we're different. Our patients are the sickest. So you can't compare us to the next person. So this actually gives us a comparable cohort where we can understand how we can learn to improve care for our patients. A few other additional items that I wanted to touch on. Agency for Healthcare Research and Quality has a survey instrument that every hospital is required to, within this period of about 18 to 24 months, do an assessment of their own organization. How do your team members perceive the safety culture in your organization? Are they scared of speaking up? And what you'll see from that second lowest domain, that is what we call response to error. This is the domain that basically says, is your organization, do they feel comfortable speaking up? Do they feel comfortable saying something's not working, it's going to cause harm to a patient? And what you can see nationally, this is not a very favorable domain. And nationally, our healthcare community is telling us that we're scared of speaking up because if we speak up, we're going to get blamed. And it really what the question should be, it's not the individual who's being blamed. So you need to move from a blame-full culture to a blame-less culture so people speak up. So this is what we call, and what I'm showing here is if you look at the blue bar, 63%, 100% is where you want to get to. This is our response on this survey after we implemented something called a just or a fair culture, which I think I lost the slide. But the just or a fair culture is really a program that says, how do we encourage people to speak up? And then how do we measure that? So that is called a just or a fair culture. This healthcare is a little late to the, healthcare as an industry is a little bit late to the table as far as becoming highly reliable. So when you think of industries that are highly reliable, think of the aviation industry. How many planes are in the air right now and how many fatalities or crashes are going on, right? Your luggage is a different issue. Your luggage may not get there, but the actual plane is doing well. The other one is, so the aviation, nuclear power plants, oil rigs. So you think about the safety record in those organizations, it's pretty good. So healthcare now is starting to say, what can we take from those industries, adopt and adapt? Because remember, when we take care of patients and people, but there are definitely lessons that we can learn from these other organizations and apply them to healthcare. So many organizations, healthcare organizations you'll see across the nation now are on this journey to high reliability. Workplace violence, we heard right at the beginning, and when the dean mentioned that violence is becoming a pandemic in itself. The hospital healthcare industry is not immune to this. I think we as healthcare providers have said for the longest time, it's part of my job. It's okay to shout at me, spit at me, throw things at me, because I'm here to take care of you. The reality is it's not okay. The mere fact that we have to have magnetometers at the front door, we have to put people through screening, we have to do all this. It adds time, it adds burden, it adds moral distress. So we are seeing an increasing number across the nation through the Bureau of Healthcare Statistics that workplace violence is increasing. And I would challenge us that the numbers we're seeing are lower because people are still not reporting it. So this is another pandemic. It's hard to take care of patients. It causes delay in care, it causes burnout, and it causes suboptimal care as well, because you don't want to go in that room, that patient's going to yell at you, spit at you, or your colleague is also bullying you. So one is visitors and patients, and it's also colleague-to-colleague violence as well. The other thing I want to mention is this is the slide. I am not going to go through this, so you can take it. This is something I presented at the Institute for Healthcare Improvement just after kind of the 12 months into the pandemic. It's a very busy slide. It has a lot of work in it that we did. What I remember from the pandemic is we have 10,000 employees in our organization. What I remember most vividly is the silence, resounding deafness, because the only people in the hospital were the people who were actually taking care of patients, cleaning the room, delivering food. Everybody else was not required to come into the hospital, but that silence was absolutely deafening. This is a body of work, there's a huge amount of work that we did. And what I want to leave the healthcare community with is that how do we globally, nationally, and locally say something that we were talking about yesterday? How do we take all the good things that we learned? I can tell you about 80% of what was on this slide, we are still doing. We've just refined it, we've tweaked it, but those structures and processes we put in place at that time to improve outcomes, we are still doing. So how do we take those and not fall into that trap of analysis paralysis and take months to do what we did in literally days and weeks during the pandemic? And I think that's a huge opportunity for the healthcare community to go back and say, how do we maintain some of this? Because it's so vital to operations. We developed vaccines in months, something else that would have taken years, if not a couple of decades. So I will leave us with that parting thought as the, how do we embrace the pandemic, the lessons learned, and what we can adopt and adapt moving forward. And with that, I think we're good for lunch.
I think we're good. Thank you
Excellent.
so much. Thank you. At this moment, I'm going to invite, we're going to mute the cameras during lunch while we get ourselves together for the web virtual folks, but I invite you all, the folks that are on here virtually, to please feel free to put your questions in the Q&A boxes, in the Q&A box, and we'll get to them when we come back in our second half in, what time is it? I don't know, in 15 minutes? Okay, we'll be back here in 10, but we're here, but the point is we'll start back up in 10, 15 minutes. So thank you all very much, and we will reconvene. For our virtual participants, we will start shortly in 2 to 3 minutes, so stay tuned. Okay, folks, we are back. I hope the virtual participants can hear us. Now we are going to get into some questions from me. I have several questions for our panel. And then after I go through a few questions, we can actually then go ahead and take the virtual audience questions as well as the in-person questions. Let me change slides. Oops, I need to start recording again. Let's see. No, it is already recording, I think. It is already recording. Okay, good. All right. Go to them. I guess. Okay, so we heard from everybody about what are all the major challenges happening across nations, which are similar across nations, right? And we heard that from all the speakers. I have a few questions I want. Here, I will give you all the microphone when it's time. Sit up and down. I want to start out with a question from mainly targeted to the Irish and the UK folks about Brexit. You all know about Brexit. Hopefully, I hope you all know about Brexit, what's been going on. So my question for you all is, what's been the impact of Brexit on the UK and Ireland? Because it's impacted all sectors within these nations, you know, so healthcare being the biggest sector of employer. What has been really the impact and in general with the health system, and then more specifically impact on the workforce in the UK and Ireland? And you all can choose.
Shall I go first? Is this we okay?
Yes.
Brexit 101. Okay.
Yeah.
Okay. So two main aspects. One, as Negin says, workforce. And then there's the other assurances around devices. So the National Health Service in the UK was past tense, heavily reliant on staff from across the world. And that included the European Union. Staff there could work with a free movement of staff, could move into any country. So through common qualifications. So a doctor qualified in Spain could work in the UK. Common qualifications were recognized. A nurse from Italy could work in the UK, and vice versa, of course. The UK was a net importer of staff. So we sucked staff into the system. Not many folk went the other way. That's partly because of the English language. The British aren't very good at speaking other languages, I'm afraid. So the health system had been heavily reliant on international staff. With Brexit, that common qualifications, free movement of workers was ended. And many staff decided to return home. I'll just talk about that in a minute, because some staff, particularly medical staff, had come to the UK for their postgraduate specialty training. They'd met somebody, they'd settled down, they'd got a house, they've got kids, and their home was now here. Well, particularly for their children. So we did a study about this, interviewing these EU doctors, and they said, well, I'm going to go back home to Italy. And their children were saying, well, home is here. So they became very conflicted about where their home was and loyalty. So the huge issue. So the European Union staff, that has gone down, but by comparison, we've recruited a lot more internationally. And well, just like the US, immigration is a huge political issue. Probably, well, not for the public, interestingly enough. It was during Brexit 2016, but not so much now. For politicians, it still is. So we've been recruiting a lot more from outside Europe, which has major ethical issues, because a lot of those are from low and middle income countries when we shouldn't be. There are bans on those, but there are ways around that ban. So we're not allowed to recruit directly, say, from Nigeria, the biggest, most populous country in Africa. But there are ways around that if they go through an agency and they kind of come in a back door. So it's a major problem. The other issue that we've had is around devices. So I forget the exact title, the European Medicine Agencies was based in London, 800 highly qualified specialist staff. Their headquarters moved to Amsterdam. So we just, we shot ourselves in the foot, both feet, and lost a lot of staff, highly qualified. And of course, that is important in terms of the pharmaceutical industry, many of which are headquartered, European headquarters are in the UK or were in the UK. So I'm afraid it's not a very good story for a lot of other reasons, but for particularly for the healthcare impact, it's been pretty negative, really. Oh. On that cheery note.
And I'm curious, what has been the impact? Yeah, the impact of Brexit, you know, the UK, we have Northern Ireland, but then we have Southern Ireland. So has there been an impact on Ireland in general from Brexit?
I'll speak and then I'll hand to one of our colleagues. I suppose I wear two hats here. I'm a and I live. What I'd say is well, you can read a lot in the media about sort of like the challenges there because of the Good Friday Agreement, and you know it's not not the place I'm going to that, but there has been huge President Biden. And in fact, it's to try and get the government back up again. Northern Ireland for what the problem is, it's a border. That's the whole space kind of the optics of that. From a health and well-being perspective, we have the common travel agreement between Ireland and the UK. So there was always freedom of movement. That kind of continues on. From an all-Ireland perspective, what I would say, I think for funding streams looking at the island of Ireland. And I suppose I was a recipient of a funding award again. It was, for example, in homes, that was put together a net Ireland common issue. There from a research perspective. But sometimes, and I think that for some of the grants now, it's a challenge, isn't it? Kind of where our partner might have been someone in the UK, but in fact they cannot be then a party on, you know, of all of them. From a health professional point of view, you know, the number of places in universities for healthcare professionals exists. It's a finite number and it depends on the funding. So for nursing, you know, there's maybe just over 2,000 places a year, you know, and medical colleges would have the same kind of like numbers of what they have. The UCDs, maybe 250. And the other universities might have similar. But, you know, what we also have is a workforce crisis and a shortage. So last year, the Nursing and Midwifery Board of Ireland, they looked at the state of the register. So what they did was there's over 80,000 people, nurses and midwives registered, you know, in Ireland. And then from that, they looked then to see like the new registrants. So you could see all the new graduates from the universities joining. At the majority of people are actually seeking recruitment. And the country with the highest kind of where we're actually many the degree that all medical degrees have need to EU directives and regulations around, so that means we have movement to other countries as well. So you know, the UK, if they're say change or things like challenges, but there's also been opportunities in that kind of space, and I think that's really useful because, you know, Northern Ireland has a lot of, you know, inequalities in health, and so has Ireland, so is everywhere. But, you know, an invisible border did not stop, you know, what was actually going on for people. So in fact, having a broader lens and kind of seeing, are there economies of scale? How can we work together with the finite funding that we have to actually truly make a difference for the population that are living there? And I suppose, so that's, I'll hand over to you.
I don't think I have much to add, actually. I think on the funding issue, that became very quickly clear that actually there was not too loud advertised going into partnerships with UK universities that had been previously been quite easy and ready to do for European Union funding. That I think the guidance was not to let them lead anything, you know, they're in a transition phase, because it was unclear, you know, what the status would be. And it should have positioned actually Irish universities as now the main English-speaking country in the European Union, you know, in a very good position. We haven't capitalized very much on that. I think we're still underperforming in terms of EU grant capture, I think, in many ways. And in terms of both academic and professional benefits, you know, or results of positive results for Ireland as a result of Brexit, the problem is that we have a massive housing crisis, and the cost of livings are extremely high in Dublin and Ireland. So we haven't managed really to capitalize on that and attract a lot of people, especially, you know, with their families, to move to Ireland, because there's basically no affordable place for them to live. And if you move to Ireland, you have to move far out, you know, and that's often very impractical. I know in terms of transportation, new supply routes have been created. I think the freight and cargo is now, which has gone via the UK a lot, you know, is now bypassing that, is going straight to France. So that has created new opportunities, I think, for business. And yeah, I think that's probably all I can add. Yeah.
Can I just add one small?
Absolutely, yes, absolutely.
No, I was just going to say, I think in the context of dentistry, Brexit, but I think those two events that have exposed what we're already part of the NHS operates. So I just wanted to add that one point. Yeah.
No, absolutely. And that's true. And I think we always tend to gravitate towards, oh, COVID did this, but no, these challenges have existed before COVID, but COVID and a pandemic like this type of a situation highlighted these challenges and the issues that we already have across health systems. We have to remember that, right? So I have a question about workforce specifically. We all talked about, I think at some point, we all talked about the challenge of burnout with workforce. And that's a global thing. This is not just a US, you know, England, you know, Ireland or UK thing. I would love to see from maybe a very briefly, what are some strategies that we're using in these, you know, various nations to actually address burnout? And we did talk about that yesterday when we met with Dr. Gulati's team. But it'd be very nice to hear across the board nationally, what are some strategies that are being used to address burnout in the workforce? Let's flip these around and then give it back to me.
No, again, just in the context of dentistry, because it's obviously sort of the area I work within, I think there's definitely, you know, the very first thing that we needed to do was raise awareness. I mean, dentistry, as well, thinking about dentists specifically as a profession in the UK, has the second highest rate of suicides. This was a statistic we had prior to COVID. So there's clearly an issue there. As we were saying, there was an issue there already. So I think, you know, the first kind of steps were really around sort of raising awareness. There's been some really good work in terms of signposting and collating resources and directing the professions towards resources and support. But these strategies have really been about targeting individuals. And I was talking a bit about this yesterday, but the World Dental Federation have actually launched quite recently a toolkit, and that's targeted. That's looking at targeting interventions at 3 different levels. So yes, targeting at the level of the individual and signposting and guidance and support, but also at the second level in terms of targeting interventions at an organizational level, and then finally at a national level. So, at organizational level, it's thinking about, well, how, it's creating a situation where managers are able to look at demands, look at relationships, support and training, and this not be seen as a deficit. If someone's suffering, it's not a deficit within the individual that needs to be addressed, but actually how do we create resilient systems that prevent people getting to that point in the first place. And then even in terms of thinking, well, how do we make well-being a component in service redesign? How do we make it a component in commissioning services, the structure that we have in England? And what's the role of the regulators in terms of well-being? So it's kind of trying to get people to think beyond the awareness raising and the signposting. And we're not there yet, but we're starting to think about those questions in Scotland at least. So I don't know.
I think in England, we're not resourced yet enough to address the burnout effectively. Because I think they're so understaffed still, but there's still pressures on the staff that are left and that remain in the NHS to pick up the workload of those that have left. So there's still, they're still having excess workload, etc. So I don't think they've reached a place where they can address it effectively, but they are introducing, bringing like more mental health support and stuff into the workplaces.
Okay.
So
Okay. I'm going to bring this down here. And I would like to say that when we talk about burnout and staff, I just want the audience to know we're talking more than just the clinical providers. We're talking about anybody who is part of the healthcare workforce. So the non-traditional staff, the administrators, these are things we have to remember. It's more than just the MDs and nurses. It's everybody who is in the field and is working. So that's really important to recognize, actually.
There's an issue that I don't think we've mentioned particularly much, but I think it does contribute to burnout, which is the bullying and harassment that goes on by clinical, health service staff, clinical staff, on other staff. I think we're only in the UK, only just starting to get into that. I just move the rock and see what's underneath this. And I think there's quite a high level, or surprisingly high level, when we think that should not be happening. So just to go back to Brexit for one example, we interviewed staff about their views of this, and there was at the time there was a famous photograph taken of an operating room staff, and all of them held up a sign with their nationality, and every single one had a different nationality, not British. But many of the people we spoke to said that there was quite a high level of this newfound love for them, whereas in previous times there had not been, and there was quite strong overt racism among staff, not being given the opportunities, not being allowed to progress in their career. So it's not as if we are in this happy community that we are all working together, and I think that contributes to burnout. So I think there are some strategies working towards this. There's a doctor who, an emergency room doctor in a nearby town to Birmingham, who runs a program called Civility Saves Lives. I think if you just put that into Google, you'll find it, Chris Turner. And there are some programs like that that actually contribute. And I think those are the sort of things that we can make sure that it's not a toxic culture, that it's a compassionate culture, not just for patients, but for staff as well.
A couple of things to keep in mind as far as burnout, workforce shortages. Remember I said there's gold and old. So there's a lot of folks who are looking to do things in their retirement years because they start to retire and they realize I still have more I want to give back. So trying to recruit seniors to come back in, I think you'll find very helpful. And one of the main things to think about for your culture is a culture of safety in terms of your own physical safety and the safety of those around you. Not only what we say to each other, but the actual safety of going and coming to and from work. And then just what it feels like in terms of how safe you feel there. And I think those two things are really major contributors to attracting a good workforce.
So one of the things that this is actually pre-pandemic that we put into place was actually rounding up on the units. And one of the questions would be, you know, what brings you to work today? How's your team doing? What's going well today? And the other question would be something around, do you have the tools that you need? And I will tell you 98% of the time, they didn't have the tools that they needed. And there were very small things. It was like the curtains in the rooms. You know, the curtains come from one corner of the hospital and somebody else has to hang them. But to the person on the bedside, that is a huge, you know, disruption to their workflow. The other thing is a very small thing is if you think about it, often when you look at your environmental care service people, especially during the pandemic, we told them they were our infection prevention ambassadors because they just felt like we're just cleaning dirty rooms. But that wasn't the case. We were telling them you are helping us in this. So I think it's gratitude. It's very important. We don't do it often enough. And then just making sure people have the tools that they need. It's so hard if you're spending half of your day looking for stuff, right? And that's not going to make any of us happy.
Anybody else have anything to add to that? Yeah, Kate?
I think in the Irish context, what came in the middle of Brexit after the first wave and where people were kind of getting major cyber and to go. So get some like then there was absolutely no infrastructure. So that was dreadful. A lot of no idea of it highlighted or they not even know how much they had as far as they got, and then on their bottom line. And for a lot of us, we don't actually know what our bottom line is. We have to keep going on. When we look at any of the, you know, we don't know all the data. Colleagues in school have looked at maternity care. They just, it was a happening. Who are these people? Who are they? We're not all just one big group with a big band behind us, you know, we're all the exact same. So it depended who we were, who's around us if you lived alone. In Ireland, of time, then I went to 5 kilometers. And working in contact tracing, we did that so into one contact. So for me, working in contact tracing in hospitals, you had to have permission to be able to travel. There were points stopped. You couldn't fly out of the country. It was actually complete. So public health legislation came into lockdown, you know, and you could really see why, but actually the impact of that for old people, they were at home. Everybody outside now, what you're, you know, that kind of people need to integrate because for so long there was a fear. So if we look at people at different population groups, what is actually supporting them becomes from a caring for people and their family. I'd say from the university Personal tutors. So we have an allocation of 1 to 24 students. To all those students, action then to student advisors being put into mental health services within the university, because there are waiting lists and you don't want waiting lists in the university. So there's an acknowledgement of is, but it's not a you problem, as I said yesterday. And I also think for all of us, you know, I was a mom and schools were locked down. So in fact, it was actually managing the knock effects of that. You know, we can compartmentalize our lives when we go out, you know, that kind of, when everybody's around you and people, you can see the implications of that and actually what's going on for younger people. Then actually students and actually what they've foreseen as their opportunity. And there they were coming to college, just sitting in a bedroom. And some of them had no idea. That kind of, it really flagged up the inequities in society and how people in the workplace had to identify actually what they had. People had to come out kind of going, actually, we share a laptop and my kid's using it for their school. I think we normally would never have to say. I suppose one of the university, that as an online, that was tremendous in 2020 for myself, and because actually it was a one time for people being able to share, because normally nobody talked about it. What actually people's fear of it. So then I took that learning and I would bring it into the was that space of actually a ripple effect, actually even calling it for and saying this and talking, I suppose, Michael West in the UK, and where he's written about compassionate leadership. And actually, you know, really seeing what was there and thinking about all those pieces. But for some people, you could say mindfulness, that's their kryptonite. So for other people, it could be, you know, it was find what works for you. But in fact, we need to be able to create a space where people can speak about it without judgment. And I think that's the important bit. So it's probably ongoing. That's what I would say.
And as I'm listening, I'm just thinking that the pandemic, a lot of our learners who needed to be at the bedside for their learning were not at the bedside for a good part of 2 years. So they had not touched a patient. They had not physically face-to-face had a conversation with a patient. So I think we're going to start to see data now about all of our learners as they're coming out into the workspace to say, there's going to be some safety, quality, empathy gaps, because they never had that opportunity. So I think we're going to see those numbers increase even more, because now they're going to be overwhelmed to say, well, how do I actually interact with a patient or a colleague? So I think that data is going to be forthcoming. I know the accreditation body for trainees, which is the ACGME, is actually listing that as another pandemic that we're about to see. So it's going to be interesting I shouldn't have used that word. It's going to be enlightening to see what that data says.
No, I was just gonna add, because we were talking this morning in the hotel before we got the bus over. But I think one of the things that we really need to do is reject this mode of sort of personal responsibility in terms of mental health and well-being. And I actually wrote this down on the plane over. But I visited Belfast a few years ago, and there's a mural. At least there was a mural there. I don't know whether it's been painted over now, but there's a lot of murals. And it really sort of spoke to me. It says, stop calling me resilient, because every time you say, oh, they're resilient, that means you can do something else to me. I am not resilient. And I actually think I tried to look at where the quote came from, and I think it's actually maybe originated in the States in response to Hurricane Katrina and the situation in New Orleans. But I just thought that summed up quite well. You know, we've got to focus on how to prepare or repair the system to support people, rather than providing sort of individual resilience training and that sort of thing, which was quite in vogue at one point in the UK. So
I couldn't agree more. I think it's if we always assume it's a person environment interaction, you know, so whatever people bring to the table, but what they're not operating in a vacuum. And we see that Kate mentioned the personal students that we have, so they're hugely diverse experiences, and depending on the environment they're operating in, but they're also themselves hugely, individual, diverse. They bring different abilities, skills, perceptions, feelings, to context, and then you throw into the mix, the human interactions, the human that happen in those contexts. So you have different staff ratios, you have different mood swings on every day, dynamics that happen, and you have different patient configuration there. So I think a one size fits all strategy won't probably work. So it is something that is highly circumstantial and has to be tailored and cognizant of both the person side factors and the environment side factors. So, and it's a system dynamic, that's unfolding over time, but I would agree. I think we'll probably see things that we don't even know what to ask, at the moment, because those things become visible probably over the years to come.
No, I just want to emphasize like the importance of the organizational changes and the structural changes. At ARC, we did a learning community for primary care practices across the country during the pandemic, because they were really left out of a lot of the response, but they were on the front lines dealing with it. And we did, basically the topics we covered, like they shared, innovation, shared how they were dealing with it, identified challenges. And we did do a session on, worker burnout, which is really hard in primary care. And, somebody just said, don't tell me to do yoga. And it's like, not that yoga's great. I do yoga. I'm not yoga, but that's not, the really needs. And I think you're right, like at all of these different levels, that you need like the policy to support workers. And then you need to create that supportive workplace culture like you were talking about, Mangla.
Absolutely.
If I just add, so the flip side, sometimes used as a flip side of resilience, is vulnerability, and I don't think people are vulnerable. People are not per se vulnerable. There are no vulnerable populations or groups. What makes them vulnerable are the circumstances, processes that link them to their environments, so that puts them into a vulnerable situation. And so I think we should stop probably putting nice labels to people and rather thinking of, what's creating those the processes.
Yeah, go ahead, Jeff.
What is the reward for doing a good job? More work. So we wonder how we get to where we are. Yeah.
I can,
So,
at firsthand, Joe.
oh, I know you do. But when you see that happening, we don't know when to stop. We just keep piling on. Some people think you can do more with less, and you can, but you can't do everything for everybody forever. So you just got to know when to say, slow it down, give people a break. And we're not really good at that, because you don't want to what? Do less work. You want to do more work.
Absolutely. Bill can keep that. This is actually a nice transition. I want to kind of shift the discussion to the aging population and prevention, and in general, how to address some of the challenges with this. And this actually ties into what Taylor just brought up, is that it's not the individuals that we talked about, it's the externalities, all the other factors that really contribute to these challenges. So we talked about, again, Arlene and Joe specifically, you all talked about this demographic change naturally that we have and the aging populations. This is a global, it's not just in our country and certain other countries. And it's a challenge to health systems overall. And we're seeing this. One of the things we always talk about, and we try to talk about, and we're saying this is the solution, is an integrated model approach to addressing perhaps this challenge and maybe other things coming up, right? But implementing an integrated system itself has many challenges. And that's why I kind of want to hear from you all. What are the challenges you all have seen and you perceive and you think moving forward in developing integrated care models of, for aging populations and other vulnerable populations, because there's a lot of factors involved. We have 2 months.
Go ahead, Jeff.
The power of the healthcare delivery in the future is not going to be getting bigger. It's going to be better integration. Because if you can't work together and get some synergy out of sharing resources, you're not going to get a stay ahead or keep ahead with the game. You just can't do it. And when you think about integration and you look about how we built our systems, we didn't build them to be integrated. When you go to medical school, you got what? You go to medical school. When you go to nursing school, you go to nursing school. You go to dental school, the same thing. How do you take those disciplines and be able to leverage them in such a way that you get more out of it? And when we look at healthcare organizations around the country, we see places where they get resourced. They're not the places that are doing the most amount of work. Okay, they're not getting resourced because they're too quiet. They're too far down the food chain, we used to say, to really catch the attention of folks what's going on. Optometry care, just on the elderly for a second. Optometry care. Are you weaving that into your primary care? Are you sure people can see the instructions you're giving them to take home? Can they read the label on the pill bottle? Can they see well enough to drive their car? Can they see well enough to navigate their way around a community? Can they see well enough to actually go to the bank and take money out of the bank? So their vision is just one area, but you just can't separate out. A lot of people here. Other people. Doesn't make it worse. It just makes it another need. We don't think about it until the critical stage of I can't hear anymore. Feel anymore. My feet. Oh, I don't have a feeling in my feet. Well, they have neuropathy. They have had it for a while, but no one ever picked up on that. So you have to look at the picture. If I could do anything in healthcare, I'm left Missouri. From our language. We're all people. We don't take care of people as people. We take care of them as a disease process, as a test procedure that we need to do today. But what did that person have to deal with to even get to your facility? And what do they got to deal with to get home from their facility? How do they deal with childcare? How do they deal with their time off of work? We don't treat them as people. We treat them as patients dependent upon us to tell them what they need to do. And we don't listen to the rest of their story, which is how they fit into society. So.
Oh. Okay. Okay. So I want to just say that there is really an impending crisis that's going to be as big as our health system. Of care that are effective, we haven't been able to scale and spread them. Work, and I'm also thinking about all the work that the John A. Hartford Foundation is doing, the friendly hospitals. And you know, so sort of changing. Somebody once said, to change from what is the matter with you to what matters to you, and can we meet people's needs and goals? And then the fragmentation, because we have underinvested in primary care and geriatrics, and we have a specialty dominated system. You know, how many of you have heard of polypharmacy? Right. So that's a big, you know, people are on 10, 15, 20 medications and interactions. It's a big problem. Well, there's another problem among older adults that causes bad outcomes, and it's called polydoctoring. So people are seeing, you know, 5, 6, 7 doctors that are all telling them to do different things, giving them medicines with, you know, drug interactions or drug disease interactions. And so how do we really develop person-centered care? And I believe we can do it. We had a round table at ARC on, like, you know, and we brought in all kinds of people from multiple sectors. So from not only health systems and professional societies, but public health and the area agencies on aging and people doing, you know, social and community-based organizations. we all need to work together to make this happen. But we had a big discussion of how do you move the needle? And there was this big debate, is it, payment, incentives, or is it policy and regulation? And then it's like culture. So you need all three of those to align and to really move the needle. And I don't know how we're gonna do that, but I think, there's a huge opportunity. And the last thing I just want to say is if we fix it for, older people, if we increase our focus on prevention, it's going to help. Everybody needs that when they interact with the health system. So it's what we're doing, I think, will benefit all people if we have a person-centered integrated system.
And then I also want to turn the question to the UK because they're having a lot of, I was going to say, after Mangala, I want to turn the question to the UK because you all are having challenges with integrated care, and that's a big problem in the United Kingdom. So go ahead, Mangala.
Right. I just wanted to add from the US perspective is the payers need to be at the table because half of our barrier is the payer. They won't pay for this. They won't pay for home nursing services. They won't. You have to get pre-authorization on a medicine takes 20 phone calls. And if somebody's not able to navigate that system, the chances are they're going to give up. So I think the payers are critical to this. And I think we need some real policy to make the payers accountable for integration.
Integration is probably one of the hottest words in the particularly the English health system. Remember, there are differences between Scotland, Northern Ireland, and Wales as well. But integration is words about what's quality, and every word has its moment, doesn't it? So, and that's partly because for the last 30 years, the English system has been through a much more competitive model of competition and much more of a kind of market orientated approach. And many people have pointed that out, but there has been a bit of a reintegration, reconnecting all the parts of the system. Problem is that that's a complex system that is under strain, workforce, finance, etc. All the pieces of the hard. Regional integrated care systems. It's actually in the title. And so these cover about 1 million population across cities, counties, and their purpose is to really pull together all the players, primary and secondary care, social care, voluntary and community groups, pull them in together to have a much better integration. At the moment, they're less than 1 year old, and so any judgment is to be reserved. We don't quite know how that's going to work out, but the ongoing crisis, financial, workforce is not making their job any easier.
Okay. Oh. Booming Northern Ireland voice, so people can't hear me. There's something wrong. Yeah, that's right. Population, 13% of the population aged over 65. I often think about the national program. It's called Integrated Care Program for Older People, for that integration of care. But COVID-19 highlighted, and especially in relation to the nursing homes, because in Ireland we had about 8,500 people died as a result of COVID-19, and 27% of them were in nursing homes. And when we looked at the economics and how people end up in nursing homes, it's because early developed structures around actually providing care to people in their homes. And in fact, it was an incentive for actually people then to go into a nursing home, and that their home, do you know what I mean? It was called the Fair Deal Scheme. There was actually a system created, but it was almost like a feeder into that. And now people they now have the data and the reality of that situation, that congregated settings, may not be the correct way. And for me personally, and I don't know for any of you sitting in this room or online, what would my vision be for how I'm prepared for when I am older? And when we talk about older, what does that look like? You know, what number do we put on that? We have a longitudinal study in Ireland called TILDA, you know, like, and it's again following up a cohort study from age 50 and older. And now those people are into their 60, over 65 now anyway. But it's always that thing around a number. And it's quite interesting how services are targeted to when you reach an age. So my sister is kind of head of safeguarding in London, and she would say, you know, when you're around safeguarding services, when you're 18, you move out of child safeguarding services because you're an adult. But for any of us, and I use this in class now, and I'd say to anybody that meets me, I kind of go, what age did you become an adult? Because for many of us, do you understand the people, some people in the, when I guess I kind of go, when I got a mortgage, when I, you know, am I an adult? So, and it's the same thing for when we are older, you know, that expectation. So for me, it's almost not having programs of care for when someone is older. It's actually moving the dial back and going, what is wellness for people as we move along, and truly embrace population health and prevention, which is always like the Cinderella service, you know, the health. It's foregoing, you know, you have to invest now to prevent. So it's actually bringing it back and saying what you're saying, everything that people do, how people live their lives. And when we get to people say it is the age over 65, and now economics are telling us in Ireland it'll be over 70 when you can retire. So we push it out because of economics, not because of your access to services or your how much you can contribute to society and things. Other people make a decision around what you do and where you get to there. So, but we're all not the same. So again, it comes back to the environment and the context of your life, you know, as to what's around you can support you to have a healthy older life, you know, what that looks like as you age. And for, you know, one of the studies we did many years ago it was a national study looking at loneliness and social isolation in older people. And again, identifying what did that look like? So for any of us, we can say we're lonely on a day, do you know, kind of, because it can be that. But what came out of that study, it was a Wenger scale that we used, was actually we broke it down into, you know, like social and emotional loneliness and romantic loneliness. And they were questions that normally we never, you know, there's questions, we don't go there. People are people, but it's just, you know, an age puts a limit on how we can often integrate with people, or the lens of, well, what does that older person look like? And yet I was just looking online, and it's someone, is it Martha Stewart or someone on the cover of a magazine who's 81 years old? And do you know what I mean? So it's, you're only as old as you want to be, you know, in your own mind's eye. So, you know, I think we, from a health services point of view, we need to engage with people, and we need to ask, actually, what do you need? Like you say, what matters and what's important, and actually really harness that. And for me, it's always, what would I like? You know, actually, what would I like? Would I be comfortable with that? You know, and I'm always kind of think out of the box, you know, so that idea of, just because we see even nursing homes, you know, if I don't know what nursing homes or care facilities look like in the US or in Maryland, but in Ireland, you can go in and it's, you know, the congregated setting with a large room, you know, a sitting room with chairs around, and I've nursed in, you know, kind of paired in them. And people can have their own rooms now, you know, it's kind of what it is. And you can personalize it. Some people might bring some furniture or things like that there. That will not work for me. And I kind of think, you know, the internet, iPads, you know, one television in a corner, someone comes in and turns the button. You know what I mean? So I don't know if it's different here, and you're going to tell me you've got iPads on the wall and you're doing all that, because that's what but it would have to look something very different. So I leave.
Thank you so much. I'm gonna start using this one. So this one, I think we're having a bit more.
It wasn't your voice, it was the technical difficulty. One of the questions I asked during my presentation is, how do you define a senior adult? Okay, now you have your own mind's eye of what a senior adult's about. And how many of you are looking forward to moving to their nursing home? Not too many people have that as a lifelong ambition, is to move to a nursing home. So how do you prepare at your age today to end up where you want to be in 20 or 30 years from now? Because if you don't know what it's like, and nursing homes I can describe nursing homes just like you did. And there's nursing homes that would knock your socks off with the things they're doing. There are whole communities where people are playing pickleball 4 days a week. Some people don't even know what pickleball is. 3 years ago, but I mean, clearly the aging process in our cultures, all our cultures, has changed. In the United States, we have a program called PACE. You guys know what PACE is? Now, this is not a test, okay? But it's a program of all-inclusive care for the elderly. That's totally different. So if I want to live in my home, I can enroll in a PACE program that will allow me to live in and die in my home. Okay, but you're going to have to what? Do other things, get to your doctor's appointments, but there's programs that will work with you to allow you to age the way you want to age. And the worst thing that can happen to you is to have a stroke. Okay, or a heart attack or something else that's going to now drive the decision for you. When my mother-in-law had a stroke on Halloween years and years ago, our grandkids only got to know her by visiting the nursing home for 10 years. That's how long she lived in a nursing home. That's not what they wanted to do. She and her husband had bought a home in a condominium that was really very nice for senior adults. Unfortunately, it had no health care benefits or no health care services. There's programs called continuing care retirement communities, where different ways, shapes, and forms you can move into and live in, enjoy life, not cut grass, not have to cook, have a meal plan, have an indoor swimming pool, have a pool table, not in your living space, but in the community. So how do you want to age? And most folks at younger age don't know that. They don't know what is available to them, and then how to prepare to be able to land where you want to land. You don't get to make the decision once you have the stroke. So before I hand this over, senior adult, who wants to answer the question? What's a definition of a senior adult? I'll take three. I got to get at least three answers. One in the back. 65 plus. If anybody's over 65 plus in this room, I'm sorry, that's the way she feels. Okay. But again, you're right. It's age limited. We always drive it back to an age. What else is a senior adult? Perfect. But give me your idea of a senior adult then.
Hold on. We need a microphone.
I said, my idea is not an age to it. It's more as I grow older, I want to maintain my health, my mobility, my ability to travel and be engaged with my family.
I came up with one I'll share with you, and you can use it for the rest of your life. So you're going to leave here today with something new. A senior adult for me, and I'm older than probably most people, if not everybody in this room. Okay, a senior adult to me is somebody older than me, which means I will never be a senior adult. Okay?
Thank you. Go ahead, Arlene, and then we'll go to the virtual questions. We have a few there, and then we'll open up to the audience.
So I just want to call out ageism. It's a huge problem. It's in our culture all the time. I watch Seth Meyers or, making these pigs at older people. Or perception, I'm thinking of other cultures. The longevity report from the NASA. What these people who are sick with and you look at the quips and the stereotypes, it's all over the place.
Absolutely. This is a huge problem, and we see it in media everywhere. Yeah, but-
Sorry, just one very quick one, really, which is in the UK, life expectancy for some women has been falling. The poorest 10%, the life expectancy has been falling. So I like a lot of the positivity, but there are some very negative aspects at the moment, particularly for some people on lower incomes, and particularly women, interesting.
40 to 45. That's what shouldn't.
Say that again.
If somebody has a life expectancy of 40, what's the focus on getting the life expectancy to 45? Even though it's the quality, it's not the quantity, it's not quantity, it's quality. And your point was perfect. You know, what do you want to be able to do as you age? Because remember, your health is your freedom. Without your health, you're what? Totally dependent on others.
Thank you so much. We're going to quickly transition back there, to walk back there to read a few of the virtual questions. All right, we have Dr. Sherry back here who's going to read them.
Okay, so this is from a attendee for Dr. Lati. This person says, I'm interested in what, if any, work is taking within the address and challenge.
I could probably speak on this for hours. If you go to the concept of psychological safety came from outside of healthcare, because again, healthcare is still learning these things. And the concept of psychological safety is I should be able to speak up whenever I'm worried. And somebody should listen to me, right? And not say, why are you speaking up? That's irrelevant. So we went to the literature and we really looked out there, and there's a lot of work by David Marks, actually a lot of it from the NHS, and the guy for the Swiss cheese mark, James Reason. And they basically put together a kind of an algorithmic approach of when something happens that didn't go as anticipated. And the first question is always, did you deliberately make this? Did you deliberately do this to hurt someone or to do something bad? And then you go through this algorithm and it really goes down, was this human error? I'm a human, I'm going to forget. And I'm going to forget in a really badly designed system. Did I make a decision, even though I knew the consequences, because I've drifted from good practice because everybody else is doing the wrong thing and nothing bad has happened, so it's okay? Or did I purposely say I'm going to do a bad thing that's going to hurt someone? And that's reckless behavior. So this is that concept of just culture that I touched on very briefly. So if you want to have an organization, and again, it's not just healthcare, aviation, anything, the food industry, you need people to be able to say, we need to speak up. We put a program in place in 2019. And if you remember the graph, I showed you the bar graph from the HREx survey. Before we put anything in place, we were only about 40% of people felt comfortable speaking up. And that's pretty bad, right? And after we put this program in place, we're about 64%, which is still not great, but it's better than where we were. During the pandemic, we continued this journey. We didn't stop. We continued to train all of our leaders. We have a workshop where we train our leaders about how to do this approach. But the thing is here is that it's really moving from that culture of blame. You did something wrong. It's not the you. If it's the you, that's easy to manage. It's the systems in which healthcare practices, we're just not really well designed. If you think about a cockpit in an airline, if an alarm goes off, it's bad. In healthcare, if an alarm goes off, it's just another noise, right? It's just white noise. So I think this concept of a just or fair culture is something that as organizations develop and evolve, it's something that we all have to be doing collectively. So if I go to the UK and they're practicing just culture, I can still speak up. And you know, it's not just independent to a location. It has to be what healthcare does.
Thank you. Thank you very much, Dr. Gulati. I would like to open the audience here at this moment. Do any of you have any questions from our panelists? Remember, most of you, half of these, most program, Joe was your instructor, so. Introduce yourself and then go from.
Hi, I'm Tara Dampert. I'm an obstetrician gynecologist and currently in the MPH program.
In my the online education practice and policy program.
Right. So there are many, many things that I could relate to, from burnout to workforce, that was talked about. But like for the United States, like we were talking about, are there going to be enough, you know, physicians, our healthcare workforce? So like every year we have the match program. And every year that's the medical students that graduate. And I remember still my match day, you know, find out where we're going to go. And the people who were unmatched, you went up to the dean's office and they found you a spot. So now that it's no longer the case, there's not enough residency spots for medical school. So we have 6,000 medical school graduates every single year, and they can't get a residency slot, and they still have their hundreds of thousands of dollars of student debt, and they cannot work. There's no like little job you can get. You have to do a residency slot. So I know that there have been some discussions with Congress and how to fix this, because our residency is paid for by our Medicare. And so the Congress has to decide to increase the slots. But at some point they decide they didn't need as many doctors. And so now we hear a lot of the politicians trying to force, oh, well, we can like have more nurses. We can have more advanced care nurses, but they're not the same as us. And that's not the answer. Only 40% of these nurse practitioners even do primary care, but everyone wants to act like that's the answer. So I don't know what question I'm asking, but what are we doing? What can we do to make this better?
Yeah, I'm easy to deal with. You're exactly right. I think somebody made the comment that we're going to really have a hard time getting everything we need to deal with the adult population. We've already passed that stop sign and we haven't put on the brakes. We're still driving like we can do everything for everybody all the time, and we can't. Now, to address your specific question, there are other sources of getting additional education in terms of Uniform Services University of Health Sciences, kind of deal, public health service, other places that may also have some other opportunities to get people on board. Other people are also going overseas, believe it or not, for different programs. You don't want to have to do that. I mean, we just don't have enough people. And you're right, nurse practitioners are not the answer. PAs are not the answer. But again, why are we here? We're here because we never invested in the primary care base. And you really can't generate new residency programs. And a lot of residency programs are going away. I mean, they just can't sustain them. Yeah, that's what they're doing. Yeah. But what's the pipeline? How long does it take you to get there?
I think it's twofold. First of all, we need to invest in primary care. We have the lowest proportion of doctors in primary care, but again, it's like push and pull. It's because it's impossible the way we've structured. I practiced primary care in the public hospitals of New York City for over a decade, and we don't support primary care. We don't put the things in place where they could really love their job and not burn out and stay at it. So we have to structurally create settings that people want to work in when they train. So thinking about what is the workforce allocation for training, and what does the country need, and how do we create jobs that people, want to do for their whole careers? But on the other hand, there's a lot of primary care residencies that are not filling. People don't want to do it. And so, how do we, educate people, like create jobs in primary care that are rewarding? Because if you have an ongoing relationship with your patient, it is very rewarding when you know people over time. But you have to be in a system that lets you practice in a way that you feel can make a difference for your patients.
That's so the incentive, you took the words right out of my mouth. So if you look at the breakdown of who goes into which speciality, the proceduralists are paid by far the highest, right? You can earn more as a proceduralist than you can as a primary care physician. And we are not creating the why. We're not doing a good job creating the why. So our family medicine program is tiny, but their footprint is so large on the impact that they make. So if you think about the lowest paid doctors, physicians, it's internists and pediatricians and family medicine. And what are we talking about here? We're talking about primary prevention, and we're not investing in those fields. So I think when the graduate medical education is how we pay our residents, maybe we need to rethink that a little bit, because if Medicare, which is designed for the older population, is not willing to invest in that workforce, the problem's not going to get any easier.
I just want to get something quickly. So I'm a geriatrician. Geriatrician is the only specialty where you get added qualifications and you make less. Why? There's only 7,000 geriatricians, and most of us are not seeing a lot of patients anymore.
3,500, you said. So I'm going to move over this way, but before I hand it over to Dr. Professor Exworthy, I am going to say that we're coming up on time of our original time, which is 2 o'clock. We're going to keep going a little bit past that just to make sure that we're addressing questions. But for the folks that are here virtually, in case you do need to leave and you can't stay, we will be sharing slides with you. We're going to gather all the information of who's registered, give you contact information and everything else. So no worries about that. And we will also share the recording with you all afterwards.
Thank you. I'd agree entirely with what Mangala was just talking about, but just to internationalize it, because we're an international panel, the Commonwealth Fund has done their survey of primary care physicians, and the US doesn't come out too good, and the UK doesn't either, actually, but it's Norway that is particularly strong. And one of the reasons for that is their high degree of autonomy that they have there. So, you know, we do know some solutions that for their job satisfaction and their enjoyment of medicine, specifically medicine, you know, we do have some solutions. You know, well, first of all, move to Norway, and if you can't move to Norway, I mean, it's, let's look at giving people a greater degree of autonomy and clinical autonomy, and surprise, it might improve their job satisfaction as well. Well, that my first point was I agree with Mangal.
I think, yes, we have another audience question here, and then we're going to switch to another virtual question. Introduce yourself.
Hi, my name is pediatrician. I work in the pediatric emergency department at the University of Maryland. And one of the yes, and I get paying pediatricians. But the question I want to ask for the international panel was the effect of the COVID pandemic on child health. We talked a lot about the aging population, which if I wasn't being a pediatrician, I probably would be a geriatrician instead. But I think some of the big issues I see in the US are kind of delays in primary care and vaccinations, and especially from my vantage point in the emergency department, rise in mental health disorders, and also just incredible lack of access to primary care, as well as inpatient and critical care for pediatrics. So I want to hear from an international perspective, what are some things that you're seeing as far as the pandemic's impact on child health?
Who would like to start? Okay, Taylor. There you go.
Thank you very much. I think some of the points that you mentioned, I think is something that we're seeing as well. And I think in Ireland, the mental health impacts, the massive impact of, you know, not being able to socialize with other children over time, you know, and potentially developmental delays. One particular group that I'm aware of that has also experienced significant setbacks were children with intellectual disabilities at that time, you know, because all their services were curtailed, not available to them. So the support that they would normally get, you know, was not there, was not available. It added just like for all the families, additional pressures for the family dynamic, especially under those conditions that Kate mentioned, the extreme lockdown situation, that during that time. So and we'll probably see over the next few years, what the aftermath of that will be, and we see it already sort of anecdotally, but I'm not aware of any data. I just know of the services that closed down and of the reports that were coming in and from parents and from the flip side is this project that I mentioned, the Co-Vision project, which was that international project where we saw, I mean, not to overuse or overstress that word resilience again, but what we saw actually, given the right environment and support, how children get through the pandemic in creative and positive ways. They found ways to manage it quite well. I think that the children that are of most concern are the ones that don't have supportive environments, that don't have that family context that gives them that stability and that encourages expression of what they're feeling, what they're experiencing at that time in other ways and forms, but the ones who are left really to fight on their own, and I think those are the ones that are probably most concerning in terms of, and they're already at a disadvantage, but I think that has further pushed them back. So I think that's.
In relation to vaccinations, they were delayed because the GPs were often the general practitioners were engaged in actually primary, kind of managing this, and then the vaccinations of COVID vaccines. Public Health Nursing Service in doing their developmentals, the decision they would see leave them up to see every child in the home. So in fact, 9 months. Beyond that, children weren't seen. Of that delay, and actually some areas would have put in workforce. You can't say it's in Ireland we have about over 11,000 before the pandemic. What the pandemic did for them was that instead of them having to go temporary breakfasts or hotel rooms that they would have, these are the figures that are known, not people couch surfing. So the maternity care, and that's where they'd ring up, find a room for the night. Then they'd have to leave at 9 o'clock in the morning because that's what it was. What COVID did was they didn't have to leave. So they got somewhere to stay. What study called Growing Up in Ireland. So they have looked at the data, and they're looking at those children. There's a new cohort that they're actually going to start next year, to kind of see what they are. I would always say, we don't know. We have never carried out a needs assessment for children experiencing homelessness. They're hoping that will come, now. But you kind of think they were homeless before they were always there. And for me, what I'd say is, I know there's over 3,000 of them. When was 500 enough? When was 2,000? Do you know what I mean? When it got to 3,000 and then it made the news, do you know that? When was enough? So from public health nurses, I know that in Dublin, so that's where I was connected to service, is what they were doing was keeping families connected. So in fact, it was that space, and even throughout the pandemic, that actually they were engaging in vaccinations. They were, to keep treating, to keep kind of like visiting and things going on there. But I also know from the public health nursing service, like enuresis in children and the clinics they would have had all ended. You might have got a phone call, and I was actually speaking to some colleagues from public health. What would that have looked like in your home? Do you know what I mean? Your child is attending for a really good reason, but no one's shouting about it. They weren't on picketing, kind of going, where's the service? So there are many visible, hidden issues, probably called hospitals, or people are managing, unpacking. really what's going on with people. So it's good. Once the schools ended, we will know over. Start collecting data.
To that, we don't know what we don't know. In our pediatric ED, we have children, and the numbers are going up, that are literally living in our pediatric ED. Because we have family doesn't want them home because maybe they're behavioral or they just don't have the resources. And those numbers are going up, and we haven't talked about a national solution yet. So, you know, and then you worry about 5 years down the line, 10 years down the line, what is that individual, what are their coping skills? How are they going to assimilate back into society? And I think these are the things, again, we don't know what we don't know, but I think we need to get to know it pretty quickly, because we're already 3 years since the beginning of the pandemic.
And I think Jenny, you had a comment. And after Jenny, we're gonna go into a virtual, and then we're gonna wrap up and
child in the US, but while here, NHS dentistry in certainly in parts of Scotland is has somewhat fallen off a cliff. In terms, we have a severe lack of access to routine treatment, and that does include children, particularly of those who come from lower income households. We have essentially what's developing. I think private healthcare and the list there it's full. The other and the cost of living, I mean, there are a luxury item, so there are some children clean their teeth pandemic, but I think again, yeah.
this is an issue in the US, trust me, the dental care is a big issue. I think we're gonna go to a virtual question, and then we're gonna have a quick wrap up, and then we'll go.
You refer to emotional distress and burnout as staff to take care of the patient. Within Canada, healthcare settings, the ideas of moral distress and moral injury are also used to talk about this experience facing workers. When you shared it, it seemed that these ideas would also reflect how the COVID strain was experienced by workers trying to find stymied in doing so. And they followed up and they said that I think this question was already discussed. So question A makes sense to focus.
Go for it. That was a loaded question, loaded.
Main disclosure is that I'm an angry, burnt out. This come from. I don't know. and we have people lunches. And my favorite thing is to bring in a relationship. Get right. Talk to and being with them during their anxiety, despair, death. I don't do as much anymore because the task allocation, task saturation is so great. Sure, what the light at the end of the tunnel is. I'm optimistic that it's there. Brighter, younger nurses will come into the system and we'll figure it out together. But I certainly don't know what it is.
Joe, did you want to say anything? No, 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 no. Well, I think based on the timeline that we've passed, I think we should go ahead and just wrap things up. I did have a follow-up question, but I think we've pretty much talked about everything. We're good to go. I do want to, let me share my screen because I want to remind folks about what's happening tomorrow. And let me just quickly share my screen. Let's see. It's this. There we go. This is actually on our School of Public Health events page. Again, a reminder that we have a second session tomorrow. A lot of you are already registered for that, virtually and in person. And then tomorrow, we're going to follow up on these conversations in a different way. We're going to have a session by the doctoral students, candidates and students that are in this room, as well as a few that are, one that went away, Portia Buchanga, who was actually with our Health Policy and Management Department, who's been one of the team members of HREx. We're also going to have, come on up. My friend, you, come on. We're going to, you. What? Tony. Tony also, yes, you are. Your award just for being you, my friend, just for being you. And also Tony is also going to be joining the students because he's a doctoral candidate with the University of Birmingham in the morning for the talk. And then the afternoon, we're actually going to continue our discussion about equity, health equity. And we're going to have a special talk by Professor Mark Exworth here about health equity challenges in the UK, because they exist. And and we talked about that, there's a perception of, oh, you have a single payer system, everything is hunky-dory, it's great. It's not. And there are a lot of equity issues in the UK. So we're going to have that special topics talk in the afternoon. I want to thank everybody that came today. If you all have, I'm sure everybody has more questions. We will put the contact information of everybody for you. We're going to share the slides. If you have any other questions about the research network, the Health Research Exchange Network, contact me, contact Professor Exworthy and a few other people here that we are member institutions and we developed this network. Feel free to reach out anytime, especially for the students and early careers. And this is what is for. All the wonderful activities and projects and research and practice that we're developing. So utilize this because it doesn't come along too often and it doesn't exist too often. I'm going to say thank you. Did you?
Say that the networks that we have, there's a whole group of similar students like you in Dublin, in Birmingham, doing a whole range of projects. I've got students looking at absenteeism in healthcare, looking at access to healthcare, looking at different welfare systems around the world. So yeah, there's lots of other people there. So use us to kind of network. If you're looking for an international partner or somebody else who's working in your area, then yeah, come and talk.
Absolutely. We are working as a group. We are working very hard to develop projects for the students and researchers in our member universities. So this is a great opportunity. We're actually actively working on comparative projects, healthcare, health system projects. So again, reach out from all the different departments in the school and then from the respective folks in the other member institutions. Thank you again one more time. I just want to, I'll put this down so I can clap. Panel, and thank you for coming, and we hope to see you tomorrow for the next set. Thank you so much. Thank you for the virtual participants.